I think we will get started. Welcome everybody to the third Cardio-Rheumatology Symposium and our first fully virtual symposium. We are bringing this to you today. It's an event organised by the Cardio-Rheumatology Network at the University of Toronto. And we have an inspiring faculty of guest speakers from across Canada and the US today who will provide us with updates and insights into a variety of topics relevant to the pathophysiology, diagnosis and interdisciplinary management of cardio-rheumatology disorders. I am going to be handing over to my co-director of the cardio-rheumatology program, Dr. Lihi Eder, who is going to provide you with further background of the symposium, our network, and a lot of important housekeeping information for the symposium today. So I'm going to hand over to you, Lihi.
Thank you, Paula. Hi, my name is Eder. I'm a rheumatologist from the University of Toronto. And Dr. Harvey did not introduce herself. This was Dr. Paula Harvey. She's the co-director of the Cardio-Rheumatology program here at Women's College Hospital. So it is my pleasure to welcome you all to the third Cardio-Rheumatology Symposium that we are holding this year for the first time virtually. I know that we have lots of viewers, including many viewers from outside of Canada. So thank you so much for joining us today. And we have a full agenda with some excellent speakers that are going to teach us about cardiac manifestations in rheumatic patients from their experience and from their area of research. So why cardio-rheumatology? Cardio-rheumatology refers to a relatively new field that studies the cardiac involvement in patients with rheumatic diseases, how to manage them better, how to diagnose patients, and the underlying mechanisms of these comorbidities. Cardiovascular diseases remain the #1 cause of death in patients with rheumatic diseases, and the relative risk ranges somewhere between 30 to 70% higher in these patients compared to non-rheumatic patients. Just to give you an example, a patient with rheumatoid arthritis has the same risk of having MI as a patient without rheumatoid arthritis who is 10 years older. So these diseases have a huge impact on the quality of life and survival of patients that we manage. And one of the reasons for establishing this network was the significant gaps in care that remains present in rheumatic patients that we and others have published on. This is a study that we've completed in a large cohort of patients with psoriatic arthritis and psoriasis, where we've shown that most of the patients that were seen in large academic centers were undiagnosed for their high cholesterol levels or for their blood pressure, and certainly were not managed appropriately for these comorbidities. So there remains a lot of things that we can still do to improve the lives of these patients. So with these gaps in care in mind, we established the University of Toronto Cardio-Rheumatology program in 2017 with the mission to improve the management of cardiometabolic diseases in rheumatic patients. Our network has 3 domains. We have a clinical arm that includes a primary prevention clinic where we refer patients for an assessment of their cardiovascular risk factors and management of these risk factors. We also see complex cases of cardiac involvement in rheumatic patients. The second arm of this network includes research. We study how to improve the prediction of these cardiac comorbidities in patients, how to use new biomarkers and imaging in clinical practice. And we also study the underlying mechanisms of these comorbidities in rheumatic patients. And the third arm of the network includes education. We try to transfer the knowledge to clinicians from our field, from rheumatology, cardiology, as well as to family physicians, and as well as to researchers and patients as well. So this symposium is part of this educational arm of the network. So who are we? We are a multidisciplinary team. This is a picture from a few years now. We were much younger and smaller. Dr. Harvey, Paula Harvey, and myself are the co-directors of the network. Dr. Shadi Akhtari runs the primary prevention clinic. She's a cardiologist. We also have coordinators and trainees that you will meet some of them later on this day. Our network is also expanding beyond our hospital, and we have another a primary prevention clinic run at Mount Sinai Hospital in Toronto that is led by Dr. Bindi Korea. We also collaborate closely with vascular imaging. Dr. Elsie Nguyen is a radiologist from Toronto General Hospital, and she collaborates with us in many of our studies, as well as in the primary prevention clinic. These are some of the pictures from previous events that were held in person in Toronto, and you will identify some of the speakers here. And this year, this is the first time we are holding this event virtually, and you can see that we have lots of participants from different parts of the world. So welcome you all, and thank you for joining us. So a few housekeeping rules for today. We have a packed agenda. This day is going to be divided into two parts. You should have received two links for these days. So the first link is the first part until 12:15, and this will include live lectures. And the second part of the day, starting from 12:15, is going to include a panel discussion with all the speakers, and this will have a separate link that you will join when this session starts. We do encourage discussion and engagement, and we really want to hear your questions. So please feel free to post any questions in the chat box. We will monitor the chat box, and we will dedicate 5 minutes at the end of each talk for Q&A, and we will also have some time during the panel discussion for unanswered questions. You can also interact with your friends and colleagues through these tabs in the platform that we have. So feel free to send chats, posts, sorry. This event is accredited, so at the end of the event, you will be able to download the certificate of attendance. And we also are interested in your feedback, and we want to try to improve this event. So please let us know what do you think about this day and how we can make it better for next years. If you do encounter any technical questions or problems, there is a tab here for a live support. We have an excellent IT team that will help you with any technical problem. Finally, we are recording this event, and we know that you may not be able to attend all of the session today live, and this will be available a week from now for a period of 6 months, so you can go back and watch the recorded sessions. And finally, I really wanted to acknowledge the contribution and support for having this event. We received non-restricted educational grants from these following companies. So I really wanted to thank them for their support. I also wanted to acknowledge Keith Colaco, who is a PhD student working in our program, who organized these days. So without him, this would not have been possible to hold this day. So thank you, Keith. You will meet him later on. He will be presenting one of his studies. So without further ado, I'm really happy to present our first speaker for today, Dr. Vincent Piguet. Dr. Piguet is a professor of medicine in the University of Toronto. He's also the division director of dermatology at the University of Toronto. Vincent was trained in Switzerland and then moved to the University of Cardiff and moved to Toronto in 2017 to become the division director. He's an investigator of basic science investigator in studies inflammatory skin diseases and virology, and published in very high impact journals such as Cell and The Lancet. He's a close collaborator. We work together on several projects. And Vincent is going to talk about inflammatory pathways and comorbidities in inflammatory skin diseases. Thank you, Vincent.
Good morning, and thank you, Lihi, and I would like to thank Dr. Eder and Dr. Harvey for having me here today. I was told it was a local event, but then I realized now we're international, so that's absolutely fantastic. I'm delighted to talk to you today about inflammatory pathways and comorbidities in inflammatory skin diseases. As many of you know, often skin diseases are associated with joint issues, particularly psoriasis, but there are a few other ones. And so it was appropriate to include that aspect into today's focus. So I have disclosures that are mentioned here. Most of them are because I'm running a division at the university and at the hospital, and we need support, but also I do some advisory work for some of these companies occasionally. So I'll get you first to a few basic sort of concepts about dermatology. I also will have a couple of quizzes to try to see if that system even works. I'll move on then to specifically inflammatory skin diseases and a little bit of the immunology. And then after that, we'll move on to comorbidities. And I'm aware of time, and Dr. Eder told me I really have 20 to 25 minutes max, so I'll stick to the schedule. I'm originally from Switzerland, so we'll see if I can manage to function like a Swiss watch. So inflammatory, this is the first quiz, and let's see if we can do the poll. I know members of the audience are not particularly involved with dermatology, so which one is it? Inflammatory skin diseases are a group of diseases, and are they rare and affect less than 0.1% of the population, or are they frequent, like inflammatory bowel disease, like Crohn and so on, and affects 0.3% of the population? Is it 2 to 6%, or is it as common as type 2 diabetes? Go ahead, just click. It won't be held against you. Just use your gut feeling. All right, so I guess we will be there. So you saw the answer. I think most people thought it was 2 to 6% of the population. So I won't give you the answer now, but I'll move on to the quiz 2. So the second one is much easier. There's only 2 choices. Are comorbidities in inflammatory skin diseases frequent and need multidisciplinary management, or are they uncommon and then dermatologists can take care of it? So I'll come back to that at the end, and then we'll see if we still agree with both major or main choices for the answers. Thank you. Great participation, by the way. So a major role for our skin, of course, is protection, right? And the skin is basically our barrier, but also our interface with the external world. And you can see, for instance, protection from mechanical stress. If you get a tear in your skin, if you fall or something like that. Of course, it's a protection against thermal injury and chemical injury. It's a protection against liquid loss. And for those, for instance, who run in the heat, you're aware that you lose a lot of liquid. So that's a role for the skin, is to allow that. However, there are conditions such as atopic eczema, where the skin has a barrier defect and there's an increased liquid loss compared to normal skin. Of course, the skin is also a very critical line of defense against pathogens, and I've done quite a bit of work in looking at how viruses can cross the skin, including mucosal surfaces. And then finally, of course, the skin is also protection against the UV radiation. And we know, for instance, that individuals who have defects in DNA repair, such as patients with xeroderma pigmentosum, which you can see at the bottom of the slide, will develop multiple tumors at a very, very young age. So the skin is really critical to protect us from sun damage and eventually the risk of skin cancer. Many pathological processes can lead to very severe skin diseases. And of course, in academic settings, that is more frequently what we deal with. On the left, for instance, you have an example of metastatic melanoma. The second one, you must be very familiar with that. That's autoimmune disease, scleroderma. We deal often with drug reaction. That's an extreme form here with the so-called Lyell syndrome or TEN. Also, skin infections are relatively common, including some of the sexually transmitted diseases, and that's an example of STIs rather. That's an example of syphilis. And then finally, you also have in the hospital at Women's College, but of course, wound management is a really important part of dermatology, including diabetic foot ulcers, venous leg ulcers, etc., and inflammatory ulcers, of course. So when you combine all these things are relatively uncommon, but when you start combining them, you can see it becomes quite a busy world. So dermatology has evolved a lot. In the 19th century, the dermatology was very visual, right? And this is an example of the French tree of Alibert, who was one of the founders of the French School of Dermatology, and where each leaf was a diagnosis. Well, believe it or not, we still have over 2,000 diagnoses in dermatology nowadays. So unfortunately, the leaves still exist, and we haven't really grouped these disorders maybe yet in a more mechanistic way, and it's still very descriptive. In the 20th century, there really was a lot of work around correlating the pathology with the clinical presentations, and that led to all the non-targeted therapies. And the joke, of course, is that dermatologists only use topical steroids. It's absolutely true. However, it's annoying because we have moved since then to the 21st century, where now we do use a lot of targeted therapies, and perhaps in some areas, even more than most other specialties in medicine. And of course, you've recognized here psoriasis and PSA, and that's an example of a situation where skin and joint are affected at the same time, and targeting inflammation will greatly improve the patient's outcomes. So my specific areas of investigation in dermatology, I started doing a lot of basic science, so more on the immunological side, looking at things like dendritic cells and pathogens and skin inflammation. But also more recently, and in the more recent years, we have done more clinical studies, outcome measures, and recently, of course, many collaboration, very exciting with the team here, and particularly Dr. Eder. So I'll just start with a case that we saw at the hospital some time ago. It's a courtesy of one of my colleagues, Dr. Alavi, who is now at Mayo, but was in our team earlier. So this is a male patient with pustular lesions all over his body. But in addition, he also has nodules in the folds, so these sort of erosions as well, or ulcerations rather. The patient also complains of joint pain, initially in the hip, now also in the ankles, and it's bilateral. So after some investigations, the patient fits two diagnoses. One is the SAPHO, which is an entity which associates synovitis, acne, pustulosis, hyperestosis, and osteitis. But also he's got these boils in the fold, and that meets the criteria for a condition called hidradenitis suppurativa, or HS. So as you realize already, this is an example of one of these patients. He has obviously major skin issues, but not exclusively. He has major joint issues as well. So we had to, of course, arrange a rheumatology consultation. We started him on a combination of antibiotics to try to control his skin issues, or at least improve them. Then a workup was done. He was started on methotrexate after the blood work, and then there was an application submitted for biologics. And so SAPHO is an uncommon autoinflammatory syndrome that can be associated with HS. And of course, these are the type of patients that represent therapeutic challenges. So what are inflammatory skin diseases? And I've talked about that without really explaining what it is. Well, it's a sort of loose group of diseases in the same way that gastroenterologists, for instance, call it inflammatory bowel diseases. But typically the major, I would say, or some of the major components of these inflammatory skin diseases are the well-known disease psoriasis. But maybe even more frequent than psoriasis is atopic dermatitis, or eczema. Most of us, have heard about that, and maybe many of you have some eczema. It's a very common disease. Hidradenitis suppurativa is oddly more common than I even knew a few years ago. I thought it was a rare disease, but it's actually quite common. And the last one on this list, and there are many more, of course, but is pyoderma gangrenosum. It's another one that's often multidisciplinary. For instance, when patients have Crohn's disease, these sort of skin ulcerations can be associated with Crohn's disease. So if you combine them, and that was the answer to question one of the quiz, most of you already know all of these things because you said it was 2 to 6% of the worldwide population. And it is true for psoriasis and atopic dermatitis combined. I think it's a little underreported, and I wouldn't be surprised that it's actually closer to 10% because although that's the official numbers we have, if you look, for instance, at primary care visits, either in the UK or in Canada, I believe like 10% of these visits include a skin complaint. So probably it's a higher number than that. But as many things, it's hard to measure exactly, especially in certain parts of the world. So when I mentioned about immunology for skin diseases, it has become critical. When I was a resident, we looked at these diagrams like this one, finding it was very interesting, but that had no practical applications. And that has obviously completely changed. We know now, for instance, that cytokines such as TNF, IL-17, IL-23 play major roles in psoriasis, for instance. And more than that, of course, we use routinely now these drugs, these biologics that disrupt specifically all these cytokines and have remarkable results. And for instance, if we think of some of the agents such as the IL-17 blockers or the IL-23 blockers, we can remove about 90% of the psoriasis on the skin in about 90% of the people. So it's a remarkable clearance. And again, when I was training, we used to admit patients on the wards. It was just before the TNFs were used in dermatology, and the wards were filled with patients with these type of conditions. And now we don't really have wards anymore as a result, because most of these patients have been able to be managed in outpatient context. In eczema, it's a similar idea, but it's just a different pathway. The critical pathway in eczema is more Th2 related, and currently IL-4, for instance, inhibitors are remarkably effective, probably even a little bit more than the conventional systemic. So really the immunology here, it's less advanced, I would say, at least in routine practice than for psoriasis. We have less agents available, but there will be more in the future. There are already some agents that are practically, I think, that will be accepted very soon, that will be added to the list in addition to IL-4 inhibition. So what is the prevalence of psoriasis? It's estimated to be about 2%. There are two peaks, but what's important is 1/3 of the patients are considered moderate to severe. What that means, it's patients that will need more than just topicals. So that's a quite big group in the end. There are external factors for these patients that will worsen the psoriasis, some of the lifestyle factors such as alcohol, tobacco, weight, and also other triggers such as medications. Certain drugs are well known to trigger or worsen the psoriasis. And some bacteria also, for instance, strep can cause flares, the so-called psoriasis cutatae. So what does psoriasis look like? Well, it's a complex disease, and it is actually having many comorbidities. One of the major ones, of course, is PSA, arthritis. And we know that sometimes the skin manifestations can happen before the joint involvement. So it's important for, I think, dermatologists and also family physicians to recognize if there's a skin psoriasis, if you like, check the joints, or at least ask the questions if there's any joint pain, and perhaps refer to rheumatology. There are many associations. One of the big ones, of course, is the metabolic syndrome. There's often patients that tend to have too much weight. There's a large number of cardiovascular pathologies, and it will be discussed by my colleagues later. Other areas are things like Crohn's disease, very frequent associations, and also mental health issues such as depression and other anxiety, etc. So the pathogenesis is clearly, it's complex, and there are many variants to psoriasis, but plaque psoriasis is, I would say, primarily a Th17 disease. If you disrupt that pathway, it's really highly effective to control the skin manifestations. And this is an example of the immunology. There's an important role for an initiation of inflammation in the skin through this LL37 complexes that will trigger dendritic cells to activate, and then subsequently there will be a sort of inflammatory cascade that leads to both the influx of inflammatory cells, T cells in the skin, as well as keratinocyte proliferation, which will lead to the skin thickening that you can see in psoriasis. And this is what it looks like. I'm sure many of you, most of you know this. It's well-demarcated hyperkeratotic plaques, typically over the areas of friction, such as knees and elbows. But of course, psoriasis is a much more complicated and broad disease. You can have psoriasis in the folds, you can have psoriasis on the nails, you can have pustular psoriasis, you can have erythrodermic psoriasis, you can have nail psoriasis, and you can also have so-called palmoplantar pustulosis. And it's clear that not all of these forms of psoriasis respond exactly to the same agents. So it'll be interesting in the future to see if this is one disease or actually many different diseases that we just have grouped together because of pathology. So in conclusion for this part, psoriasis has a great morbidity, physical and psychological. The biologics are clearly a revolution. They have remarkably transformed the lives with patients who have severe psoriasis. But there are many questions open. Are there other areas where we can use biologics in those variants of psoriasis that are less well understood? Access can be a big issue for biologics because of cost. And of course, it's the sort of safety and efficacy in the long term. Some of these agents are relatively new, so we'll need to learn more about them in the coming years. The next part of my talk, I'll briefly cover HS, or hidradenitis suppurativa. And the reason is it's a less well-known disease, but it's, I think, relevant, and I think it's more common than we realize. And what struck me when we first started looking in this field is that the impact on quality of life is similar to very severe psoriasis. It can be even worse. We did those studies ourselves, and we found that actually the impact on the quality of life is even greater. It's characterized by the presence of inflammatory nodules or abscesses in the folds typically, and you need an element of chronicity. It needs to happen 2 to 5 times, so it's not just a one-off, but it has to be a sort of repetitive. And the presence and the prevalence is still relatively uncertain. It ranged from cohort studies in Denmark from 4% of the population among, for instance, young women, to insurance database claims in the US where the prevalence was 0.05%. And I, as a resident, we didn't see those patients very often. So I was curious to do some research in this area. And the person who convinced me was one of my residents when I was the chair of dermatology in Cardiff in the UK and Wales, Dr. John Ingram, who is now leading there. And John told me, you know, Vincent, you should get interested in that because it's a much more common disease than we realize. And so we embarked. This is what patients typically look like. It's areas of scarring. It's a very painful disease. And it's, I know the images are a bit difficult. I apologize for that. Also, more so when you do an ultrasound of the skin, you realize that even if you see just a little hole on the skin, it's actually much more than that. You can have those tunnels under the skin that go sort of all the way through across the whole anatomic area. So you can have, for instance, the entirety of the axillary area that's basically one very large tunnel. And of course, medication alone is not going to be the answer to this. So how frequent is it? This is a study that we published in the British Journal of Dermatology, led by John Ingram. And this is the prevalence. We know that there are more female patients than male patients, and that was from the CPRD, so the database of primary care in Britain. And we realized actually that the prevalence of HS in the UK population, that was on millions of patients from the database, 20 million, I believe. The prevalence is close to 1%. So it's much more common than I would have assumed. I thought it would be 0.2, but it's almost 1% of the population. That matches several other studies that have been done. The female to male ratio is 3:1, so more common with women, although men sometimes have more severe forms, so it's not necessarily easier to treat male patients. And HS has a huge cohort of comorbidities such as smoking, obesity, hyperlipidemia, pylonodilus sinus, acne, Crohn's disease, and depression. And that was from our study in the UK. But since then, there's been even more associations reported in a variety of cohorts. You can have rheumatology manifestations, and I think we have contributed some work recently in this area where some arthropathies are associated with HS. PCOS, of course, is also associated with hidradenitis with HS, and then a number of other comorbidities, particularly in the area also of mental health, which these patients are very severely affected by their disease and often has a great impact on mental health. So in addition to that, you have sort of genetic or variants which are associated with HS, which are syndromes. And another common association is Down syndrome with HS. And I have a few of these patients in my clinic, actually. And of course, a few other more uncommon genetic disorders. So what is the mechanisms for that complicated disease? So there seems to be a component that's genetic, although we don't fully understand it yet. There is a dysregulation of the immune system. Clearly, factors such as weight or tobacco play a role. So there's a role for environmental factors, and then there's a role for microbes as well. And this is a diagram that summarizes some of that, where this environmental triggers the genetic predisposition that leads to this sort of hair follicle plugging that will lead subsequently to these abscesses and inflammation, and ultimately it will result in these scars and a tunnel formation and plus or minus presence of bacterial elements. So if you look at the blood also of these patients, you do find elevation of a number of inflammatory markers, especially in the severe form of HS, things like IL-6, IL-8, IL-23, and so on and so forth. So the bacteria in HS, it's a really interesting area, and I've been really interested in this for a while. And it's not thought to be an infectious disease, and the presence of the bacteria do not mean infection. And in fact, lymphadenopathy or a true infection is relatively uncommon. They play a role more in terms of causing dysbiosis. And this is a study from our colleagues from Germany who scanned the microbiome in patients with HS and noticed significant differences. So that the concept that we have, the two issues with bacteria in HS, one is the bacterial presence causes this dysbiosis, and I'll come back to that. And then the second aspect is that bacteria can cause biofilms, which are basically like glue, if you like, on the skin that will prevent the healing. So you do need sort of medical surgical treatments for the wounds to remove the biofilms, otherwise the wounds won't close. And antibiotics may be helpful, but it's not an infectious disease in the conventional sense. So The main concept is on this slide, is a review we did a few years ago with Haley Nyquist at UCSF, and the infection versus dysbiosis in HS. And most people think, most scientists, most clinicians think that this is a disease of inflammation. However, we do have some colleagues that think that infection per se plays an important role, particularly the team at Institut Pasteur in Paris. And they're doing studies now to target bacteria more specifically. So it'll be interesting to see how the field evolves in the future. And again, a little bit like for psoriasis, there's been a lot of advances with therapeutic targets in HS, but many of them are very early targets. So they're just in observational studies. The only licensed drug for now for or I would say the only licensed and demonstrated target for HS is TNF blockers, particularly adalimumab and its biosimilars. But there are a lot of other targets that are interesting. Bacteria themselves are a target, and antibiotics are used extensively. IL-1 has been used, so anakinra and similar drugs. IL-17 inhibitors are in trial, so we'll see what the results are. And complement inhibitors have been used as well. So HS management, it's a complex management, and you can see here how dermatologists won't be able to do everything, right? You have a sort of lifestyle management. Often we have to do it with other specialists. There's a wound care, so we will need a wound care team. You have a use of antibacterials, and sometimes we do have to rely on infectious disease specialists as well for tailoring the antibiotics when needed. Biologics are a major part, and we use them extensively. And then, as I mentioned, some of the tunnels, for instance, you need to perform surgery, so that would be in the hands of a surgeon who is familiar with the condition, and generally won't be a dermatologist. The procedures will be sometimes very extensive. So typically, for instance, Crohn's, colorectal surgeons might deal with those patients, or plastic surgeons, and so on and so forth. In Toronto, we're very fortunate with two plastic surgeons, Karen Cross and Ralph George, who are leaders in this area and are really helping us tremendously, and mostly our patients, of course. So that's in conclusion for this part. The HS is managed both medically and surgically, and you can imagine the more you have scar and sinus formation, it's more of a surgical treatment, whereas if you have a lot of skin inflammation, it will be more of a medical management, which can include antibiotics and biologics. So in summary, HS is an inflammatory skin disease with multiple phenotypes associated with a large number of comorbidities. There's a role for genetics, bacterial presence, environmental factors. The management is complex and requires a range of specialties. And there's still many areas of unmet need, particularly delay to diagnosis. Even last week, I had a patient who had this for 14 years and had not been diagnosed. And this is kind of the norm, where many patients take more than 10 years to be diagnosed. And of course, there's a number of other areas that our colleague from the US, Amit Garg, published recently in the JAMA Derm, are barriers to access to care, for instance. So in the last 2 minutes, and I realize I'm running out of time, I just wanted to show very briefly a new way to measure skin inflammation, that is mass cytometry. Basically, it's a way that you can label tissues with multiple colors. We recently published an article on this, if you're interested, and it's called tissue mass cytometry. And the way it works, you use a machine. You can have slides, your blocks with, let's say, for instance, skin samples. You label them with all the antibodies at the same time, and then you can analyze pretty much each cell for the multiple colors you have included. So instead of having 2 or 3 colors, as we used to have by immunohistochemistry, you can have up to 30 different dimensions. And so what it will look like is something like that. That's an example of skin of psoriasis. And you can see on the left part all the different infiltrates with the various subsets of cells, such as T cells, neutrophils, etc., etc. And then you can use bioinformatics analysis to reconstruct this population. And you can see, for instance, all the way to the right, a normal sample will have a low number of these inflammatory cells, whereas the psoriasis skin in the middle samples will have a lot more inflammatory infiltrates. So we're really excited about that. I think it will transform how we understand skin and tissue inflammation, so joint and other things, and we're just at the start of that. And with that, I thank you for your attention. This is a picture of UOT. I really like it. The fairly not very nice building, that's where my lab is. It's the MSB. The beautiful hospital is Women's College Hospital at night. And then on the bottom right, it's the Mars building, which is where some of the research is taking place at UOT. Thank you for your attention, and I welcome any questions. These are our funders, the supporters. We're supported by the hospital, particularly by Dr. Harvey, but also we are at the center of the Skin Investigation Network, which is a CIHR-funded network for skin research in Canada, led by my colleague Anwen Chan from Dermatology with us. And yeah, that's it. Thank you.
Thank you, Vincent, for a very comprehensive talk about inflammatory skin diseases. It's so nice, I guess, or interesting to see that we are facing the same problems with rheumatic and dermatologic patients. I guess we have some time for a couple of questions. We do have a comment from Helen Beatty that mentioned that from the psychiatry literature, from Roger McIntyre group at the University of Toronto, they've shown that brain inflammation is a major causal element in a variety of depressions and bipolar diseases. And I guess this further highlight the role of inflammation affecting multiple organs and the underlying mechanisms of different comorbidities that these patients are facing. I guess please feel free to send any questions. Maybe I can start with one question about comorbidities.
Maybe comment on the comment. I think it's true. Inflammation, especially when you have systemic inflammation that can depress the mood. I think we are very convinced about that. Some patients almost overnight will get better if you, use an anti-cytokine. The mood improves quite rapidly. However, I think there is also an upsetting, component for skin appearance in many skin diseases that are not necessarily linked with a lot of systemic inflammation. So I think there's both aspects where you can have, and I have patients, for instance, I had a patient who had really bad psoriasis on the hands and really quite limited, no systemic inflammation, very depressed. He had lost his job because they said his employers didn't like his hands. So I think it's many factors. We underestimate, I think, also the impact, not just the immunology, but also the impact on daily life, on employment. We recently published a study on HS showing how much income loss you have because of these diseases, how hard it's to be employed, and this contributes to anxiety in these patients. And so I do believe in brain inflammation. That's clearly one of these aspects, but also there are a lot of other issues in addition to that can result in mental health or anxiety disorders in skin disease.
Absolutely. I guess one question, a more practical question, and this comes up in many discussions between rheumatologists and cardiologists. I assume it's relevant for dermatologists as well. How do you manage comorbidities, having such a little amount of time to see patients and deal with their dermatologic issues? How do you screen and for comorbidities, and who do you think should take ownership of the management of these comorbidities in your practice?
Yeah, so I think that's a great question. I think it's highly context dependent. I think in different centers, comorbidities will be managed somewhat differently. It also depends, of course, on the expertise. Some places, for instance, when I was in the UK with the joint clinic with rheumatology, so we would see patients together at the same time. So the comorbidities, for instance, were immediately managed, but we wouldn't screen. But I understand in other settings when this is not possible, maybe dermatology has a role, into screening, for instance, for joint pains, and there are questionnaires, for instance, for psoriasis that are well established as sort of as a start, you can have a few questions that you ask, and then if they, and there are many of these things in a variety of area. I think the mental health piece, for instance, is very, very challenging because if you screen and then you need access, so rapid access to a mental health provider, which can be challenging. So this is an example, for instance, where it's a difficult area, particularly for us, for dermatology, where the time with the patient can be limited. How do you approach that? And I think different centers will have different views on how to do it. So I think I can't generalize, but that's how we approach it here.
Thank you. I guess due to lack of time, we have to move forward to the next speaker. We will address the questions in the chat in the panel during the panel discussion. Thank you, Vincent, for joining us, and thank you for a great talk.
Thank you.
And it is my great pleasure to introduce our next speaker, Dr. Alexis Ogdie, who is an associate professor of medicine and epidemiology and the deputy director of the Penn Center for Clinical Epidemiology and director of the Penn Psoriatic Arthritis and Spondyloarthritis program. Thank you, Alexis, for joining us. Alexis is a collaborator and a colleague and a friend, and she's one of the leading scientists in the field of psoriatic arthritis. She studies outcome measures and comorbidities in psoriatic arthritis, and is going to talk today about inflammatory path. Sorry, this is the improving metabolic health in patients with inflammatory arthritis, and in particular focusing on some of the important lifestyle changes that we try to convince our patients to adhere to. So thank you, Alexis, for joining us, and take it away, please.
Thanks so much for that generous introduction. And it's not only hard to say, but it's also hard to speak to. So today I'm going to be talking about improving metabolic health in patients with inflammatory arthritis. So, and these are my disclosures. So as I was thinking about this topic, I was trying to think about how to present improving metabolic health and inflammatory arthritis in about 25 minutes. So that was really hard. And so I came across this quote that seemed to make sense. Hard work alone does not equal success. You need to work hard in the right things. And so I was trying to figure out what are the right things that we can talk about today. Well, when we're thinking about improving metabolic health in our patients, this really is hard. This is hard work. And it really requires a team. So it's very cool to hear about the cardio room team at Toronto. And I think that's kind of where we want to start taking this whole field in terms of how can we improve things. Well, we really need to have everybody at the table thinking through this together. And so what I'm going to do today is kind of go through big picture items, and hopefully I'll stimulate more thought rather than presenting a lot of data, just to kind of help everybody start thinking about this in their own local institutions, and then how we can build programs together that will address this really important problem. So first of all, why is this problem important? Metabolic disease in our patients with inflammatory arthritis has a number of serious downstream outcomes. One of these is that it's associated with diminished quality of life. If you have lots of things going on in terms of your diabetes and your hypertension and your taking medications, that alone can diminish quality of life. Next, there's higher disease activity in patients who have multiple comorbidities, and in particular these metabolic comorbidities. Patients who are obese or have metabolic disease have poor treatment response, and so we don't get as good responses to therapies in these patients. And finally, there's the ultimate problem of increased mortality. So we know that many of our diseases, including rheumatoid arthritis and severe psoriasis, for example, as was just discussed, are associated with increased risk for cardiovascular mortality. And this has also been shown in some studies of patients with psoriatic arthritis, particularly those studies from Toronto. So as we think about this big, important problem, what are the key issues? What are the key things that we need to address in order to improve outcomes? So these things include increased risk for the cardiovascular outcomes that I mentioned. Next, there's an increased prevalence of cardiovascular risk factors in these patients. So patients with RA, psoriasis, psoriatic arthritis, they all have higher prevalence of hypertension, diabetes, obesity, hyperlipidemia than our patients in the general population. Next, we don't have good ways of predicting cardiovascular outcomes. So the cardiovascular risk algorithms that are available today don't work as well as they really should. And Lihi has done really nice work demonstrating this, that in psoriatic arthritis in particular, our cardiovascular risk algorithms don't really adequately predict risk. And then finally, there's insufficient management of cardiovascular risk factors. And again, Lihi has demonstrated this nicely within the Canadian population. We've also found this in the UK population as well, that these patients, the actual prevalence of treatment for cardiovascular risk factors is relatively low. So all big problems. How do we kind of boil this down again into something that we can actually create strategies around? And what are those potential strategies? So again, very large, big buckets. One, you just heard a great talk about inflammation and the association between even just skin disease and systemic inflammation. The same is true for joints. So our patients have high levels of inflammation. There's been some really nice studies linking CRP or C-reactive protein and higher cardiovascular risk. Those studies have largely been done by Paul Ridker in the general population. And then in addition, Paul Ridker led a kind of a monumental trial that examined the ability to decrease systemic inflammation in patients who've had a myocardial infarction using anti-inflammatory therapy, namely an IL-1 inhibitor, canakinumab. And they found that through use of canakinumab, they decreased subsequent cardiovascular outcomes. So there's proof of concept for this concept of treating inflammation to improve cardiovascular risk. And actually, if you drill down in the data in rheumatoid arthritis and psoriatic arthritis, for example, and psoriasis, the data is less clear, but there's a lot of confounding there. So it's really hard to understand that. This trial was a really nice proof of concept. Next, there's improving disease activity. And you might say that 1 and 2 are the same, but actually they're different. So when we think about disease activity is broader than inflammation. It's how well you're able to function, for example, factors into your disease activity. And if you're able to function better, then you're probably able to take care of yourself better. You're probably able to do more walking and so on. So improved disease activity is a separate target. And then finally, there's addressing the individual risk factors. So those things like hyperlipidemia, hypertension, identifying the diabetes and treating the diabetes. So there's many different risk factors. So we have in the yellow here, risk factors that are kind of general population risk factors that also exist in our patients. Again, the same things that I just mentioned, in addition to obesity and smoking. But Ferguson and Ian McGinnis's team have written a nice review article just recently published. This is actually directly from their paper. And they talk about all the other risk factors that are specific to our rheumatic disease population. So beyond the inflammation, hyperuricemia, APLS, and lupus nephritis in our lupus patients, and then NSAIDs more broadly. We're still not exactly sure how NSAIDs in our inflammatory disease population contribute to cardiovascular risk. So how do we address these risk factors? Well, there's both the clinical team involved as well as the patient that are pieces of this. And when I talk about the clinical team, I mean broadly the clinical team. So this could be the primary care doctor, the rheumatologist, the dermatologist, and the cardiologist, all as one team. So in addition to the actual specialties that are involved, then we have the nurses, the nurse practitioners, or the physician assistants. There's a broad team that we can utilize to improve outcomes. I forgot pharmacists in there. Pharmacists are an important part of this as well. There's been some nice studies showing that utilizing the full range of the team can improve addressing these cardiovascular risk factors. For example, engaging pharmacists in prescribing statins. There was a nice study from Canada in this population in rheumatoid arthritis, and they found that that really improved getting patients on lipid-lowering agents that were needing lipid-lowering agents. So what are all the things that a clinical team needs to accomplish in order to improve cardiovascular risk? So we need to calculate the cardiovascular risk. We need to educate the patient about their risk and why this is important to their long-term outcomes. We need to prescribe statins if they're eligible for statins. We need to manage the hypertension if they have hypertension. We need to identify and manage diabetes. We need to support weight loss and support smoking cessation. So if you feel overwhelmed right now, you're in the right group. This is a lot of different things to take care of. And if you put this on one clinician, even just the primary care physician, that's a lot for one physician to kind of be managing throughout the continuum of care. And it is important to say that this is through the continuum of care. This is not all in one bit. This is not even all in 1 year. It might be over the course of time. All right. So one of the things that we wanted to know was, what are rheumatologists' perspectives on this? Are rheumatologists doing some of this or any of this? Are they primary care? How are they handling this particular risk? So we did some interviews, qualitative interviews with 10 rheumatologists, a mix of community and academic clinicians. We also did the same for 10 dermatologists in the community and some academic clinicians as well. So first we asked them about their thoughts on counseling about the risk for cardiovascular outcomes in patients with psoriatic arthritis. And they were very happy to counsel their patients about the increased risk and make a note of that in their note, maybe even hand them some information. Next, we asked them about screening for cardiovascular risk and sending lipids, for example. And then they were like, well, I don't know, that's not really within my lane. You know, they kind of felt like this is kind of straying outside of my lane. And then we asked them about, you know, if you know your patient has hyperlipidemia, would you prescribe a statin? And that's where they really started to drop off and say, you know, I'm not so sure that, you know, there's a variety of different barriers that kind of get in my way to wanting to do that. So one, of course, is the kind of staying in your lane piece, but the other one is time. So one of the critical barriers to addressing cardiovascular risk among dermatologists and rheumatologists is time. And this was in particular problematic for dermatologists who have, you know, 10 minutes in the room on a good day. So they're kind of in and out of the rooms very quickly. All right, so we dive deeper into what are some of the other barriers getting in your way of addressing cardiovascular risk. And then we divided those barriers into organizational level barriers, provider level barriers, and patient level barriers. So from an organization perspective, you know, if you're talking about dermatologists and rheumatologists, the leadership of those departments isn't really kind of prioritizing cardiovascular risk stratification and management as a part of their duties and a part of the time that they're spending in the clinic room. They saw an integrated care coordination as critical to getting this done, but actually finding that most of the times that integration portion is not really there. So it's great when you have a cardiologist in your group that you can send people to, and we actually do as well, which is really helpful. But if you're trying to coordinate with a cardiologist you don't know, who's in a different health system, a different primary care physician in a different place, that becomes a really big barrier to wanting to do this because you're not sure how you're going to coordinate back and forth. Next, there's provider level barriers. We can bill on time, but billing on time is not actually an efficient way to bill. And so you're limited on the amount of time that you're in the room from a fiscal perspective. There's also this belief that really the priority is management of the inflammatory arthritis or management of the psoriatic disease, for example. And so straying outside of there is kind of not really your job, but also there's limited knowledge and training around those other pieces of cardiovascular risk. You had that maybe in residency, but then after you moved into your specialty and you've been there for 10 years, you kind of feel like you're not quite as up on those things. There's a belief that cardiovascular risk management is not appropriate for German Rheum to do because it's out of scope of their practice. So I've kind of been through that. Then there's patient level barriers. So patients have a limited knowledge about cardiovascular risk related to their disease. It also, the ability of the provider to prescribe a statin to the patient, for example, may be different based on the relationship with the provider and whether or not that patient actually has a primary care doctor or not. In the US, it's possible not to have a primary care physician and that you come to your rheumatologist or dermatologist for all of your care. There's a perception on the part of providers that patients may be resistant to wanting to have a rheumatologist or a dermatologist prescribe or take care of her cardiovascular risk, and that there may be a personal preference for having the physician just do their job, you know, focusing on the one aspect. And then if the burden of the disease is high, that kind of gets in the way of the patient wanting to get their lipids done, address their statin, and so on, but also the provider will just really focus on the disease and let's get this disease under better control. All right, so now that we have some idea of what are the specific barriers and what are the different levels of the barriers, how can we address some of those barriers? What might be some of the strategies? I kind of talked about big umbrella strategies before. How can we drill those down and kind of make some of these more specific? So different ways of thinking about organizational barriers. Maybe we have a standard of care practice that is addressed, that we kind of move this into standard of care and we allocate time to do it. We might clarify or identify like how the patient, the provider might do this. So we might have, in the United States, we use Epic. So we have like smart sets. So there's a set of things you're going to just order and do and put that out into the electronic medical record. So you maybe create things like that. And then maybe we move toward more team-based care. And maybe the team includes a cardiologist, the primary care physician. Maybe there's better ways to communicate. But maybe our team is actually the staff within our office. So it's our pharmacist, our nurse practitioner, our nurse, and so on. So thinking about team in a variety of different ways. Provider level barriers, so education and training and consultation of physicians, allowing them to have the ability to get that training and also ask questions from other providers who have expertise in this area, and giving them the tools and the resources in order to do this. And finally, increasing patient awareness is seen as an important strategy, regardless of how we implement these things. I think what is now better understood is that a multi-pronged approach is absolutely needed. So you can't just use one of these approaches. Although in studies, we might want to test just one. We need, in reality, multiple approaches. So in order to think through this more broadly and think about what are the specific strategies we want to use, we had a meeting. Actually, Lihi was a part of this meeting as well. So we held this meeting that among patients, well, there were some patient research partners there, but also there were rheumatologists, dermatologists, cardiologists, implementation scientists, statisticians, people who think about this kind of thing in their day-to-day life. So we had NIH involvement and CDC involvement from the US as well. So this YouTube link here, if you're interested, if you take a snapshot of that real quick, that YouTube link has all those talks from that day. If you're interested in more details about the process of thinking through how do we make interventions that can be utilized in practice in day-to-day life in order to increase better monitoring. So at the end of the day, so we had a series of talks, and then we had a bunch of workshops in which we talked about what are some potential interventions and potential study designs that we might use or test in order to understand how we can better get patients with psoriasis and psoriatic arthritis to better metabolic disease control. So that would be our goal. So let's say this is just one potential model, and we're going to explore one of these different models. The rheumatologist or dermatologist will see a patient and set a goal for a patient. That goal might be, let's target your lipids. Your lipids are elevated. Let's target your lipids. So one model, it might be that there's some central program that lives somewhere outside of academia, but maybe within National Psoriasis Foundation or some foundation. And the patient is then referred to that program. That program has a nurse practitioner or someone else who can have can take their lipids and their kind of cardiovascular risk, actually perform a cardiovascular risk assessment using the data that we have available to us, and then suggest what needs to be done next. Maybe that's, you're eligible for a statin. You should really be prescribed a statin. And then that person sends a note to the rheumatologist or dermatologist who referred the patient to the program. The patient may also self-refer themselves to that program and then get that information and feed it back to the dermatologist, rheumatologist, or primary care physician. Another opportunity would be that you train a person in your practice. So let's say it's a nurse practitioner, let's say it's a pharmacist, and they do the cardiovascular risk stratification, and then they prescribe the statin or put the prescription in for the physician, who then signs the prescription and statin is underway. And finally, you could train a rheumatologist or dermatologist to do this and implement the intervention. We actually think this is probably the least likely. As much as physicians are trainable, they're difficultly trainable. So that's just one pathway, one set of pathways that we're considering. And actually, we're starting with this central program concept, and we'll probably be taking that forward into a trial design. All right, so we've talked a lot about how can we do something with the clinical team, or how can we help the clinical team to be there to help improve outcomes for patients. Now let's talk about the patient, because we can do all that we want, but the patient has to actually enact it, or they have to take the medication. So many of the things that we're talking about are actually lifestyle changes. So if I need my obese patient to lose weight, that's a lifestyle change. If I need them to eat better and address their lipids, that's a lifestyle change. And have you talked to your patient about a lifestyle change recently? And how did that go? So I love this cartoon that I found because everybody wants the pill to fix that. When I tell a patient that when a patient is asking about diet and how diet is going to influence their inflammatory arthritis or their psoriasis, I tell them, well, it might. We don't know. You'd have to try it for about 6 to 8 weeks, and then we'll see what happens after that. And instantly after I say that, they're like, okay, what's the next medication you got? So everybody wants to line up for that small pill or that surgery or something that's going to take care of it. But lifestyle change is hard. Why is it hard? Because changing behavior is hard. It's so much easier to just keep doing the same thing. But if you have to reroute yourself and go a completely different direction, that is really challenging. So we've been working with the behavioral economics group at Penn. We have a great group of internists who and other providers, there's a cardiologist as well, who think about how can we get patients to change behavior. And one of the things that they think about is behavioral economics. We recently published a paper on just some general concepts and how you can apply these concepts in practice. We gave an example of physical activity, which I'll go through, but you can apply this just about any kind of lifestyle change. So what do I mean by behavioral economics? Behavioral economics is kind of the merging of standard economics and psychology, putting those things together to say, how can we drive people or help people make changes in their status quo in order to improve outcomes? So I'm just giving some brief examples here of what are some of these different concepts. So one concept is you can give people rewards for doing something, and maybe that will drive their ability to do something. However, rewards are actually not that effective. I don't know if you guys have a 6-year-old, but they work. The reward works for a little while until the reward becomes standard, and then the reward no longer works. So, but the same is true in adults. So if you give rewards, it can be effective. But what's actually more effective is threatening to take something away. I don't know if you have a 6-year-old, that works sometimes too, but it actually really works in adults. So if you give people a pot of money in their account and you say, I'm going to withdraw money for every time you don't do something, that actually works significantly better than giving people money for doing something. Because there's this concept of loss aversion, that what I have, I don't want to lose, and that losses loom heavier than gains in the future. Meaning that if you're thinking from a standard economics perspective, we actually weight those losses much heavier than gains, especially when there's something happening in the future. Next is a status quo. So the status quo is that previous picture I showed. You can just stay on the same line, but changing the line is hard. But if you make your change look like an easy path to take, then actually it becomes a lot easier. So there's a variety of ways of changing the status quo. One brief example from a physician perspective is that if you change the ordering of medications that pop up when you type an individual medication, you will more commonly choose the one that's first. You just do what's easiest. And so if it's easiest to choose a generic drug over a kind of more expensive drug, you're going to do that. Framing, how we frame a problem or how we frame a potential solution or an outcome changes a lot how much you're going to work to get to that outcome. Timing is everything. So setting up a goal. So if you're going to exercise in the morning, setting everything up so that you're ready to go as soon as the alarm goes off, making it as easy as possible, and making sure that that's not going to get in the way of something else. So choosing the timing of a goal is really important. And finally, social norms. We want to look like the people that are our idols or kind of our mentors. And so if something is seen to be a social norm that it's cool to eat healthy, then people will do it. And there's a variety of ways of structuring that. So I won't get into detail about all of these, but these are all these examples that I'm going to I'm showing here are in this paper. But some examples for increasing physical activity, just as one potential measure for getting people to get healthier. Let's say there's a variety of different incentive strategies. One is social incentives. So if you have a competitive game versus a supportive game, that might drive different people differently. And so we might be wired to do one over the other. Patients in general want more supportive things than competitive things. Whereas people in like Deloitte Consulting is where one of these studies was done, really want competitive. So you have to think about your patient population or the population you're building an intervention for and what they want and need. Other things are giving feedback. So regular feedback helps someone stay on track better. So that could be a daily text message, for example. So we've done this a little bit within physical activity in inflammatory arthritis, and I'll cut to the chase and say we learned that financial incentives don't work for inflammatory arthritis patients if you're using small and standard economic or financial incentives every day. We did implement a loss aversion strategy, so a behavioral economics concept there, but patients still felt like getting to their goal, which was set too high for them, was not effective. So there's a lot of things to think about when you're building these different trials or studies, or even just implementing in clinical practice. The goal is so important for how you set this up. And the reward or the reward they might lose needs to be steep enough that they're going to do it. So having conversations and doing some preliminary work about how to set these strategies up is really important. And so this has helped us set up additional strategies. Okay, I'm almost out of time. So I'm going to skip through a couple things here and talk about obesity briefly. So we've talked about metabolic comorbidities and obesity being a critical piece of this. Obesity is associated with more hypertension, more hyperlipidemia, and it's also associated with decreased response to therapy and higher disease activity. And this might be through inflammation, but it could also be through inflammation generated by fat, for example, but it also could be just the general weight on the joints. So when we did our prelim work to figure out how we might address weight loss and getting our patients to lose weight, universally they say, I don't want to lose weight. I don't want to focus on losing weight. So we instead went for something different, which is diet. So patients do want to try different diets. And so Lihi and I have launched the Dietary Interventions in Psoriatic Arthritis study. And this study will address different dietary strategies. And on the back end, one of those may end up in weight loss, but it's not structured in a way to make patients feel like they're in a weight loss study. We've employed a variety of different adherence measures here. One in supportive measures, I should say. One is that regular feedback, so a daily text message in which they have to rate how their diet is doing. And that's just it's almost like a self-feedback and a way to self-reflect on what you've done today and how you might do something different tomorrow. We have personalized messages and kind of uses the stages of change model, have a pre-commitment contract, so they kind of come up with their own goals and then commit to those goals. So I won't go into detail about that, but this is just one example of how you might apply some of these things to a study. So in conclusion, metabolic disease is common in patients with inflammatory arthritis, and a multi-pronged approach is really needed, and that team approach is so important. We have to think about the clinical role and the patient's role and how we utilize some of these strategies to improve outcomes. And really, this is hard. This is hard work. We have to work together to do this, and we need these dynamic multidisciplinary teams to achieve better outcomes. So thanks so much for your attention, and I will open for questions.
Thank you so much, Alexis. This was a fascinating talk, and thank you for the amazing work that you've been doing with these new models of care. This is really exciting. I guess we have time maybe for one question. So since we don't have any questions yet, maybe I should ask you, many of our people in the audience are from community, and they don't have these multidisciplinary teams to help with implementing all these interventions that we are interested in trying. What would you advise a community rheumatologist that wants to implement physical activity or dietary changes in a patient?
Yeah, that's a great question. So I think goal setting, actually GRAPPA has developed some new modules that are going to be coming soon for psoriasis and psoriatic arthritis that help people set goals and then kind of follow up on the goals. So I think that's the critical thing, is actually just finding a goal and finding a way to track the goal. So if you hold those two things, that's really helpful. And then finding a friend that you can phone, like your friendly cardiologist down the road that can be the someone that can help you with those things, or your friendly internist that likes to work on nutrition interventions and weight loss and so on. So those are really helpful. And then peer health coaches, I just saw that in the text. We haven't specifically done that, but that has been used in some of these studies, and helping patients find someone, whether that be a supportive family member or someone else who can help guide them. That can be really helpful too.
Thank you so much.
I
think we can maybe, due to the interest of time, we can move on to the next speaker. Thank you, Alexis.
Thank you. Have a good one.
Thanks, Lihi. It's my pleasure to introduce Dr. Monica Parry, who is our next speaker today. Dr. Parry is an associate professor at the Lawrence Bloomberg Faculty of Nursing, and she's also a clinician who continues to work as a nurse practitioner in the cardiac program at Kingston Health Sciences Centre. Dr. Parry has over 35 years of clinical experience and doctoral and postdoctoral studies that have laid the foundation for her research program, which is focused on patient engagement and sex and gendered factors that impact the burden of cardiovascular disease. Dr. Parry is a colleague of ours. She's an internationally recognised scholar when it comes to sex and gender, including in heart disease. And recently, we've been working with Monica in a study that's focused on developing a digital health intervention tool for women with heart disease to enable them to participate in self-management. So Monica's talk today is entitled Addressing the Health Gap, Heart Disease in Women with Rheumatic Conditions. And over to you, Monica.
Thanks, Paula, for that kind introduction. And thank you to yourself and Dr. Eder for the invitation to present today. So as Paula mentioned, the title of my presentation is Addressing the Health Gap, Heart Disease in Women with Rheumatic Conditions. And just to acknowledge the lands in which we're on, the traditional territories of many nations, and Toronto is now home to many diverse First Nations, Inuit, and Métis peoples. I have no potential conflicts of interest or disclosures. And I really have three buckets to the presentation. First is a little bit of background describing the prevalence, trends, and disparities and the global burden of cardiovascular disease. Secondly, discuss strategies for identifying and managing risk for CVD in women with rheumatic conditions. And then looking to the future, what are some directions for research, practice, education, training, and advocacy focusing on the prevention and management of CVD in women? And I will show a little bit about our digital app that Paula mentioned near the end of the presentation. So we know that there are 17.8 million people that die every year from cardiovascular disease. It is certainly the most common non-communicable disease. This represents 31% of all deaths worldwide and 35% of total deaths in women. Certainly the United Nations Sustainable Development Goals gave us a really solid target by 2030 to reduce the premature mortality related to cardiovascular disease by 1/3. In Canada, this is really no different, and I'll come back to some Canadian statistics in a minute, but CVD is the leading cause of premature death in women in Canada. And I'll just highlight some of the work of the Canadian Women's Heart Health Alliance. We are publishing an atlas in the Canadian Journal of Cardiology Open, and they're published as separate chapters. So if you'd like to learn more about CVD in women, I would urge you to have a look at the CJC Open website. So in Canada, women dies every 20 minutes from heart disease, and in 78% of women, early signs of a heart attack are missed. And interestingly, more younger women aged 45 to 54 are dying of heart disease. And the other interesting bit is that 40% more women who have inflammatory arthritis are being diagnosed before the age of 50. So inflammatory arthritis occurs in approximately 1 in 12 women and 1 in 20 men. And it's inclusive of rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. Women with inflammatory arthritis have up to a 70% increased risk of having a heart attack. And I will talk about risk, some of the risk assessment tools that we have. And I would suggest, and I think is probably well known to some of our audience members, that these risk tools really underestimate the risk of CVD in women. So just to orient you to the slide, this slide really depicts the 10-year cumulative incidence proportion of MI on the top left, all-cause death on the top right, cardiac death on the bottom left, and major adverse cardiac events, or MACE, on the bottom right. The blue dotted line is an individual with no rheumatoid arthritis or CAD. The red dotted line is rheumatoid arthritis alone. The blue line is CAD alone. And you can just see from each one of these figures that adding rheumatoid arthritis to CAD really increases the risk across all these categories. This is an interesting publication or figure from a recent publication from the Lancet Commissions, just published on May 16th of 2021, and it represents the global CVD burden in women. So again, just orienting you to the slide, the top left are the age standardized CVD prevalence rates in women in 2019. The top right are the estimated annual change of these age standardized disease prevalence rates in women between 2010 and 2019. Bottom left are the age standardized CVD mortality rates in women in 2019. And the bottom right are the estimated annual % change of these mortality rates between 2010 and 2019. And I think what is really interesting and clear on these figures is that despite the influence of social and cultural progress and awareness in women and heart disease, there's been a stagnation in the overall reduction of CVD burden in women. In high-income regions, the decline in CVD mortality has really slowed, and I think you can see that on the bottom right map. And in 2017, it actually increased in women in the US and in Canada. And so this really is a call to action, and the Lancet Commission really wants us to target adding on to the UN Sustainable Development Goals a focus on women to reduce cardiovascular mortality by 2030. So this is the first polling question, and it's an easy one, a true false. And this was actually from a reviewer of a grant we submitted. So distinguishing cardiac pain from arthritic pain. This will be difficult since neck pain, jaw pain, shoulder pain, back pain, and chest pain can all be involved in inflammatory arthritis. So simple true false, I'll give you just a few seconds to do that. Anyway, I'm not sure how to show the results of the survey, but we'll move on to the next slide. The answer is true. It is difficult to distinguish cardiac pain and symptoms from the pain and symptoms of inflammatory arthritis. So next slide. This is a study that we undertook called Her Heart, Her Story, funded by the Women's Exchange. It was to help us understand cardiac pain in women who do have inflammatory arthritis. This was a mixed method study. We started with a literature review to really help us understand about the self-management of cardiac pain in women who have inflammatory arthritis. And although we found initially 519 studies, none of them really focused on addressing cardiac pain in women who have inflammatory arthritis. And in fact, in many of the studies, especially the studies that looked at exercise, CAD was actually an exclusion factor. We did focus groups, and this is a quote from one of the women: "I can't distinguish if it's cardiac pain or shoulder pain from my arthritis. With my angina, it's been unstable for a long time. I get pain in my shoulder and my jaw, my neck, radiating down my arm and my back. So it's hard for me to distinguish what it is." Our average age in the sample was 63. Most women had moderate stress, reduced physical function. They had moderate pain scores, scoring 6 out of 10. And most women did 18 hours of housework a week. And I'm going to come back to that when I talk about some of the gender factors related to cardiovascular disease. We also did a systematic review looking at self-management of pain in women who have CAD. And we found in that study that only 6 of the studies, or 11% of the studies, actually reported comorbid factors related to arthritis. So I think we have some work to do in how we report the demographics of our samples in the research that we do. This was a study published in 2019 from Scotland. It was a single center study, about 1,950 participants, including men and women, about 40% women. And on the left, we have symptoms related to MI, and MI was diagnosed with sex-specific thresholds using troponins. And on the right were anginal symptoms without the diagnosis of MI. The top, we have what we would describe as typical symptoms, and the bottom, atypical symptoms on both graphs. And I think what you can clearly see from this is that men represented in blue and women represented in red, there's quite an overlap in terms of their symptoms. And in fact, chest pain was a presenting symptom in 91% of men and 92% of women. So the typical symptoms were more common in women than men. And so this is sort of throwing out the window what we've thought for a few years, that atypical symptoms maybe are more prevalent, but maybe we need to kind of pass away that typical atypical nomenclature and look to see what the presentings are and their overlap. There were some differences. Women compared to men more often reported palpitations related to their symptoms, and about 38 or 31% of women reported back pain, and 28% reported pain to the neck. The other interesting thing is that in women, the combination of greater than 3 typical features, so the pain nature, the location, its radiation, and other associated symptoms like shortness of breath, fatigue, really was associated with a significant positive likelihood ratio of having an MI, and this was not present in men. So just another polling question. I'll see if I can do better in this one. So women who have heart disease will already be familiar with their cardiac symptoms. I'll let you just, again, true or false. We'll just move on to the next slide. The answer is false. Women who have heart disease still have difficulty recognizing their cardiac symptoms. These are a few quotes from our study. My cardiac pain goes to my back, and that's when it makes it difficult to distinguish between my arthritis and my heart. When I last had my heart attack, I waited till the next morning. If I were to recognize it again, I would call 911. When I'm in the moment, I don't put the symptoms together. So I don't think we can make assumptions that women who have cardiac disease will actually recognize their symptoms to seek care. So the last polling question is whether naive patients, so patients without or women without cardiovascular disease, will they be able to recognize their cardiac symptoms? So whether naive patients will be able to recognize cardiac symptoms is unknown. True or false? Okay, good. That's about 1/3 that have responded, and the answer to this one is true. And I'm going to share a short video, 50-second video of a woman who has inflammatory arthritis, also has established, now has established coronary artery disease. So we'll just take a minute to listen to this video.
So in March of 2016, March 8th, I had a heart attack. I didn't know I was having a heart attack, but I knew something was wrong. I didn't have any symptoms of what I've heard a heart attack is. As I was washing the dishes, I felt like there wasn't enough room in my chest for my heart. I felt like I couldn't get enough air in. I just couldn't breathe deeply enough. To actually be told you've had a heart attack, it was shocking to me. I knew that nothing was going to be the same. You have to become informed that women experience cardiac pain and cardiac events quite differently than men.
So a couple things that Vincenza highlighted. She was exhausted and an exhaustion she never felt before. I think picking up on some of these clues will help us diagnose heart disease in women. The pounding in my chest started again. It was shocking, and she didn't trust herself anymore. So just some work to be done. So let's look at some strategies for identifying risk. So we do have risk prediction models. We have over 295 risk prediction models that include women. There's lab-based models. And the WHO actually looked at non-lab-based models that could be used in low and middle income countries. And they validated these models in over 375,000 men and women from the years 1960 to 2013. So they're valid models. And I'll just show you a couple slides very quickly, highlighting a couple things. Men are on the left, women are on the right. And the red, dark red and lighter red color is sort of intermediate to high risk of developing CVD in 10 years. And the yellow, and I'm going to come back to this, is that 5 to less than 20%. So these are sort of the place we don't know where that risk really falls. But I think what you can consistently see with the non-lab-based models is that women have lower risk, and there's lots of research pointing to the fact that these aren't really sensitive to women and the unique risks that women bring to cardiovascular disease. So these are in Africa and the Asian populations. So this particular figure shows you the sex-specific risk factors on the left: premature menopause, hypertensive disorders of pregnancy, preterm delivery. And then we do have well-established risk factors, or the traditional risk factors, but some of these carry more risk in women. For example, in diabetes, there's a 44% increased risk of cardiovascular disease related to diabetes. So even though the risk factors are traditional, they carry a different risk in women. And then on the far right, we have these under-recognized emerging risk factors that are psychosocial, abuse and intimate partner violence, that we may refer to as gender-related risk factors. This was a study done at McGill following men and women under 55 years of age who had a coronary event, followed them for 12 months. And what they found at 12 months is it was actually gender and not sex that brought them back for a recurrent event. These are just some of the gender variables, which I'll come back to, but gender identity, gender roles, gender relations, and institutionalized gender like income and education. These are all variables that affect women differently than men. So future directions really need to focus on the Sustainable Development Goals, looking at good health, gender equality, reduced inequality, and partnerships. And so despite the social and cultural progress and awareness, we learned from the recent Lancet Commission, there's been a stagnation in the overall reduction of CVD burden for women. So we need strategies to tackle these inequities. So closing the gap through research, increase women's involvement in trials, and I would suggest we have women as patient partners. We report comorbid factors that include inflammatory arthritis and CAD. We consider and actually incorporate variables that measure gender and use these variables in terms of our research design, analysis, and reporting. We power our trials to be inclusive so we can do sex-specific analyses. And without, more solid research, we are still using guidelines that predominantly focus on men. We need to enhance awareness through education, social media campaigns, target well-established sex-specific risk factors, and strengthen our healthcare system designs. So this slide just shows you more men have obstructive coronary artery disease, more women have non-obstructive disease, and it's younger women that tend to have non-obstructive disease. So I think targeting some of the research to some of these small vessel disease links that link sort of rheumatoid arthritis with preeclampsia, with vascular dementia and coronary microvascular disease. So really looking from bench to bedside is where we need to go in terms of our research. So risk prediction models, I think I've tried to show that these aren't always accurate because they're not inclusive of the different weights or traditional risk factors bring, or really reflective of the non-traditional risk factors. And certainly Dr. Eder and Dr. Harvey have looked at this, and there are suggestions to increase risk by 1.5% in people with rheumatoid arthritis, but that doesn't always work so clearly. So the AHA in 2018 and 19 posed using risk enhancing factors, and I think these might be helpful to look at sort of that 5 to 20% group that are in that low risk. So looking at the 10-year risk and using things like, rheumatoid arthritis, hypertensive disorders of pregnancy, that would shuffle you along the continuum from high risk to low risk. And using novel sort of risk factors like coronary artery calcium through CT or carotid assessments would help you sort of move that continuum. So if you have someone in that yellow category, sort of using that coronary artery calcium to shift the risk for more targeted and aggressive therapies. So just in a couple slides in closing, this is the work that we're doing. We've built a digital health app for women to increase awareness about women's heart health and women and heart disease. It's also a self-management program for women. We have a data donation component where we'll collect data on some of these risk factors, so it in the future can be used as a repository, and we can do some research on this. So we'll collect information about inflammatory arthritis. Education that is interdisciplinary. We built some virtual interactive cases. This is an example of one of a woman presenting with, she has a history of arthritis, presenting with upper back pain. We developed these with pharmacy and medicine at U of T. You can take a history so you can see where the pain is, and then a history. And that is it. So thank you for your attention.
Thanks, Monica. We do have a question here from one of the participants.
Okay.
As a physiotherapist, we're taught that mechanical pain must be ruled in through reproduction with mechanical testing. So I guess, palpitation, movement, etc. Was this considered in the identification strategy studies for understanding causation of cardiac versus non-cardiac or joint symptoms?
Say that again, Paula.
So I guess it was, were you actually doing some maneuvers with the patients to try and tease out whether or not their pain that they're experiencing, the quality, etc., the location in these women, whether that was related to joint or musculoskeletal, mechanical versus what may have been cardiac?
Yeah,
or self-reported, I guess.
Yeah, I think that's a good strategy. Cardiac pain really shouldn't change with movement or palpation or breathing. So it is sort of a good sort of front end way to, I think, figure out if it's cardiac related or not. Some women, though, because their symptoms are vague, I think have difficulties describing their pain. So I think a really good history looking at what one might call prodromal symptoms, the feeling of exhaustion, is also helpful in interpreting whether the pain is cardiac or not, or related to joint disorders.
Mm-hmm. Just touching on something you said there is the expression, articulation of pain. We've sort of looked at whether or not there's sex differences in the way cardiac pain presents. And as you've shown, it's not as clear-cut as we used to think it was. There is this sort of suggestion that part of this is related to gendered impact on even just expression of symptoms and experience of symptoms. Do you feel that that's part of what's leading to this, this sort of confusion or the overlap, the difficulty of us trying to identify cardiac pain in women? Because Vincenza, who you presented on the video, she was still sort of presenting symptoms a little different than perhaps a male might.
You're right. So she would be like, that one study in Scotland showed that chest pain is still predominant, but that's, what about the 5% that it's not? She did have palpitations, which is one of the presenting thing in women. Gender has certainly got something to do with it. And that's why I reported the 18 hours of housework in women in our study. Their pain was moderate. They had a moderate amount of stress, yet they were doing all this housework. We have to incorporate some of those things into our teaching strategies to help women understand, that modifications need to be made. Those are certainly gendered ways of doing things. I had another video to show of another patient participant, Donna, who actually was having chest discomfort when she was having breakfast. She called telehealth. Telehealth told her to call 911. And her response was, I can't call 911 right now because my husband is eating breakfast. And she was having an MI. So their gender, we have to pay attention to gender. We have to measure it so that we can understand it better. Right now, we're not really measuring it consistently across the studies that we do.
Yeah, it really is that area of complexity that we need researchers to understand what gender means, and the importance of gender. It's not all biology.
Right. Yeah.
I'm just going to take the liberty with one more question, because you and I have worked in the area of sex and gender and cardiovascular disease for a long time. And I think we've made some progress in sort of obstructive atherosclerotic coronary disease. There's still a long way for us to go, but we're now identifying the sex-specific and gender-specific risk factors and the other cardiac conditions that impact women, the non-obstructive disease, for example. How do you think we get the message out? Because this is a new way of thinking about things, to the community and to providers, so that we can move the needle along. Do you have any ideas?
I think we need to target, because we're seeing more CAD in younger women, I think we need to shift our needle a little bit and target a younger population, maybe adolescent women. Maybe they're not thinking about coronary artery disease, but I think we need to move the needle a little bit and shift our population that we're targeting. I think we need to have some campaigns, like Wear Red Canada is a good example. Can we associate things with Mother's Day, or I don't know. We need to. It is lack of awareness in healthcare providers and lack of awareness in women, and it's a huge mountain, I think, to climb because of the complexities of traditional, non-traditional risk factors. The shift in younger women, comorbid factors, ethnicity comes into play. Hypertensive disorders in Black Canadians bring higher risks than hypertensive disorders in Caucasians. So it's very complex. So I think we just need to have a multi-pronged approach, and just continue our efforts. Yeah.
Well, thank you. We start with symposiums like today, where we're we're at least highlighting the inflammatory rheumatological conditions and their role in cardiac diseases.
For sure, yes. Thank you for the opportunity.
Thank you, Monica. And I'll remind everybody that you can enter questions into the chat, and we'll be addressing those at the end of the day when we put everything together. So it's now my pleasure to introduce the next speaker, who is Dr. Andrew Crean. Dr. Crean is a professor of medicine within the Division of Cardiology and co-director of the Cardiac MRI service at the University Ottawa Heart Institute. He's a clinician investigator, and he has a focus on uncommon cardiac conditions. So he's particularly interested in the application of cardiac imaging and molecular imaging in conditions such as adult congenital heart disease, inherited cardiac conditions, and inflammatory coronary anomalies. And he really enjoys collaborating with preclinical imagers, physicists, engineers, basic scientists, and patients to improve the care and the knowledge of the patients who are under his care, and obviously translating that information out to the rest of us. So with that, Andrew is going to be talking today on what lies beneath the hidden burden of myocardial abnormalities in rheumatic conditions. So I'm handing over to you, Andrew.
Okay, well, thank you very much, Paula. Thank you for the introduction. Thank you to the organising committee for the opportunity to talk today. And I really only have a single disclosure, and it's that I'm not a cardio-rheumatologist, but I do have an interest in this area, primarily from my time in Toronto when Dr. Harvey used to send me all sorts of weird and wonderful patients to image. So hopefully we'll see a few of those today. Now, at a meeting like this, there's often, quite rightly, an emphasis about the risk, the increased risk of coronary artery disease in women with rheumatologic conditions, and we've heard a bit about that already. But actually, I'm a rare disease cardiologist with a focus more on the myocardium and the pericardium, and I'm going to talk for the next 20 minutes a little more about those sorts of things. I'm only going to have a single slide in which I mention very briefly coronary artery disease. So let's have a think about some of these conditions and what sorts of methods we might use to detect them. So when we think about the range of problems in rheumatologic conditions, we have to understand that the tests that are available to us have different strengths and weaknesses, and I think that's common sense. And so in choosing the test that we're going to use, we have to be very sure about the question we're asking. If we're more interested in the coronaries, we're probably not going to want the same test as if we're concerned about myocardial inflammation. And of course, some of these patients have multiple problems, and we may need more than one test to get all the answers that we're looking for. So I'm going to start with my one slide in a second about coronary artery disease. I just wanted to remind everybody that CT is an excellent technique for coronary artery disease, and particularly calcium scoring, which we've already heard mentioned in this talk by Dr. Parry a few moments ago. So calcium scoring is a very straightforward CT technique. It's quick, it's low dose, it doesn't involve any contrast. The patient sits on the CT scanner for about a minute and the pictures are acquired. And then essentially what the scanner does is, or what the software does, is set an algorithm to identify calcium by using a density threshold, and that is color-coded and scored. And we can produce a number anywhere between 0 to a number of thousands. And I think this is a very interesting technique because it's now widely available and very quick to do. A score of 0 means that you have no evident coronary artery disease. You may, of course, have soft plaque, but your risk with a coronary calcium score of 0 is very low. It's very low to have a cardiac event in the subsequent 3 or 4 years. A score from 0 to 100 tends to suggest that there is some degree of coronary atheroma, but probably not obstructive coronary atheroma. However, a score above 400, and particularly as you go incrementally above 400, so the risk and probability of having at least one obstructive lesion goes up. So I think this is a very interesting test. We know that in non-rheumatic populations, some of the common risk scores that we use underestimate risk or overestimate risk. They're actually not very good at sorting out the intermediate risk group. Whereas calcium scoring allows that intermediate risk group to really be stratified into a truly low risk and a higher risk group. And I couldn't actually come across anything when I was reviewing the literature to see whether coronary calcium scoring had been routinely applied in large cohorts of women with rheumatologic disorders. So that's one of the things I would be interested to hear from the panel and the audience about towards the end of the talk. I'm also going to say almost nothing about valves, because I think really this is the strength of echo, and CT and MR have relatively little to offer. Echo obviously has fantastic temporal and spatial resolution, and really if you're trying to identify masses on valves, echo is the treatment of choice, particularly transesophageal echo. There is perhaps a small role for CT and MR in situations where there's concern about distal embolization, perhaps in antiphospholipid syndrome or Liebman-Sachs endocarditis. And CT in particular allows a very, very rapid screen, really from head to toe, in situations where there are concerns about showers of emboli. But that apart, I'm really not going to mention valves. So I'm going to spend most of my time talking about the pericardium and the myocardium. The pericarditis is actually quite common in patients with rheumatologic conditions. We certainly get plenty of referrals, particularly for patients with rheumatoid and SLE. And echo is a technique that can be quite useful here, but we're going to see that CT and CMR have some extra things to offer beyond what echo can do. Here's an example of a patient with rheumatoid pericarditis. And you can see on the echo, actually the echo is a little bit helpful here. Very often on the echo, particularly in acute pericarditis, you may not see anything at all unless there's an effusion. That's probably the commonest sign. If pericarditis has been going on longer and has become a little bit more chronic, you may see some pericardial thickening. And that's what we see in this image here that's playing. You can see the left ventricle here, for those of you who aren't familiar with echo, this is the LV. And there's a white stripe which is overlying the LV. And this is actually thickened pericardium that you wouldn't normally be able to see by echocardiography. But in most cases, when it's difficult to see the pericardium by echo, CT or MR performs much more convincingly. And here's the same patient with an unenhanced cardiac CT study. And you can see firstly that the pericardium is thickened in a somewhat circumferential distribution. And secondly, that there's calcification in places in the pericardium. This isn't too bad. Sometimes the calcification can be really extensive. And that's an important thing to recognize, because the risk of significant constriction goes up probabilistically with the more calcium there is present. And therefore, it's a way of identifying who perhaps is going to need a surgical consultation. Notice how on the echo, you really don't appreciate the calcium. You see the thickened pericardium, but you really can't see calcium very well by echo. What you can see nicely on this echo, though, is what we would refer to as restrictive physiology, restrictive filling. So what do I mean by that? Well, normally when you take a breath in, blood returns to the right heart, and the right heart is a low pressure chamber. It expands to take the increased volume, and all is good. But in this situation, you can see that the right heart is actually very small. And that's because with each inspiration, it's not possible for blood to easily distend the free wall of the right ventricle, which is being constrained by this thickened pericardium. And so we get this classic, rather low volume right ventricle with a somewhat tubular shape. And this is really very suspicious for constriction when you see this sort of appearance. And these people can't really increase their cardiac output by raising their stroke volume, and so they need an obligatory tachycardia. Now, MRI will show these kinds of things too, but it will allow us to look at some of the tissue characteristics of the pericardium. So on the right, here's a different patient with rheumatoid pericarditis. And you can see, so what we've done here is we've used something called a T2 weighted sequence, which is an MR sequence that's particularly sensitive to the presence of water. And you can see that the pericardial sac lights up with water signal all around the heart. So this is not what you would normally expect to see. A normal pericardial signal would simply be fairly dark. There isn't very much fluid at all in the normal pericardium. It certainly doesn't show up as clearly as this. If you don't have ready access to MR, there is also the potential to use CT for looking at the pericardium. And I've often found this useful in inpatients if there's a long wait for MRI, or the patient's claustrophobic, or they have a device, they can't go into the MR scanner. CT is often thought of as being simply good for coronary arteries, but actually it's really good for lots of things, and particularly the pericardium. However, there is a bit of a trick to it if you want to look at the pericardium properly and look for inflammation. So here we have the same patient and 3 different time points. We have a pre-contrast study, an arterial phase study, and a 2-minute post-contrast study. And what you can see on both the pre-contrast and the arterial phase is that there is fluid. There is, maybe you don't recognize it, but take my word for it, a radiologist or an imager would be able to see that there's fluid around the heart on both of these images. But what's really hard to make out is actually where the pericardium is precisely and how thick it is. I mean, we know it must be on the outside, but we don't really see it clearly. So if we, after this bolus of contrast, if we simply wait another couple of minutes, then inflamed pericardium will take up iodine, just as it will take up contrast agent in MRI as well. And so 2 minutes later, we get this beautiful appearance where we can clearly see the pericardium. And now this is a patient who has acute pericarditis. So the pericardium is not particularly thickened at this point, but it is taking up more contrast than we would expect. And this is consistent with a diagnosis of acute pericarditis. In fact, the spatial resolution of CT is so good that sometimes we can even identify the visceral layer of the pericardium, which is relatively uncommon to see in MRI. So don't forget about CT if you don't have ready access to MR. I see an awful lot of patients who get given a diagnosis of pericarditis clinically. I don't like that because I think it's a diagnosis, particularly in the cardiology world, it's a diagnosis that gets thrown around too easily. And I think it's important to try and find some evidence that people have got inflamed pericardium before we put them on drugs for a number of months. So please consider CT if you don't have ready access to MRI. But the reason we tend to prefer MRI if we can get it is because the signal from gadolinium is so many times better than the signal we get from iodine in CT. And so here's another patient where we've used gadolinium, and you can see this intense, bright, circumferential enhancement of the pericardium. Again, normally we would see no enhancement whatsoever in a normal pericardium by MRI. So this is really abnormal. This one's a bit thicker than the last one I showed you. We maybe have some concerns that this might go on to become a more chronic collection. We can see there's a collection in here, actually splitting the parietal and visceral layers of the pericardium. And this is the sort of patient I worry about a little bit in terms of developing constriction in the future. This is the sort of patient where I would usually like to bring them back in 6 to 9 months, just to have another look to make sure that they aren't developing signs of constriction. Because the echo example I showed you before was very obvious. But unfortunately, a lot of the cases are more subtle than that. And very often patients have rather vague symptoms of breathlessness, and they go many months, if not years, before a diagnosis of constriction is made. So one of the things we do when we're asked whether constriction is present is use a technique called real-time MR cine imaging. Now these images look blurry because it's in order to get adequate temporal resolution to follow a respiratory cycle, we don't get very good spatial resolution. So that's just one of the trade-offs in MRI. But what this technique does, it's simply a rapid sequence of cine images that are acquired while the patient breathes deeply in and out. Now, if you or I breathe deeply in or out, nothing happens. Blood rushes into the right ventricle. It can be accommodated perfectly well. You don't see any change in the shape of the left ventricle in a normal person. But in a person with constriction or subacute constriction, that inrush of blood into the RV during inspiration cannot move the free wall outwards and therefore pushes the septum over. So what we see on expiration is a relatively normal looking left ventricle, looking round like it should. As the patient starts to inspire deeply, we start to see this flattening of the interventricular septum until we reach end inspiration and the patient starts to let the breath out again, and we return to a more normal shape. So ventricular independence is an important sign to look for. In theory, this can be done by echo, but it's often harder to see by echo than by MR because we can choose our plane very precisely. So that's ventricular independence. Now, the other thing that I think cross-sectional imaging is particularly useful for in this situation is looking at the secondary effects of chronic pericardial involvement. So when we're concerned about constriction, we can look for indirect markers, and that includes things like IVC dilatation because of high right atrial pressure. And also, and particularly importantly, other really important effects of chronic high right-sided heart pressures, and that is liver hepatopathy, congestive hepatopathy. So in effect, if you have a chronic right-sided heart pressures, then those pressures are back transmitted to the liver. And this is the sort of thing that I see, for example, in my Fontan patients all the time. Every Fontan patient has got a liver that looks like this. And unfortunately, some unrecognized constriction patients go on to develop not just hepatopathy, but actually frank cirrhosis. And in my time in Toronto, I think I saw three separate patients who were believed to have idiopathic cirrhosis, who subsequently turned out to have pericardial constriction as the cause. So I just wanted to highlight that. This is a different patient. This is a patient with adult Still's disease, but it's with constriction. But I just wanted to point out that it doesn't really matter what the rheumatologic condition is. From the imaging endpoint, constriction is constriction. It's the same signature. It's a water signature, a fibrosis signature, and a signature of ventricular interdependence. So the final common pathway of constriction is the same regardless of what the cause. I wanted to move on to talk about the myocardium now. Edema, fibrosis, and scarring are three things that occur in a lot of rheumatologic conditions. And really, when you look at the table in front of you, you can see that although all of the tests can do bits, really MRI really trumps the rest in terms of its ability in these three areas. So let's look at a couple of examples. Myocarditis is probably the single commonest thing after pericarditis that we get asked to image in the rheumatologic population. And it's quite common, it seems, at least it's quite common from the papers. I'm not sure it's quite as common and clinically significant in real life. But there's a suggestion that maybe as many as 40% of rheumatoid patients, for example, may have asymptomatic evidence of myocarditis if you go looking for it. Why you would go looking for it, I'm not sure, but we don't go looking for it unless the patient has symptoms usually. But the forms of myocarditis can vary. It can be focal, it can be diffuse, it can be granulomatous, it can be non-specific. And really, if I saw something like this on MRI with these tiny little dots of white, I really don't think I would lose any sleep over that. I think it's highly unlikely that that's going to be terribly important, at least in the short term. This kind of thing is a bit more interesting. It's a little bit denser, and there is certainly a relationship between, in every cardiomyopathy, there's a relationship between scarring and arrhythmia, ventricular arrhythmia. And this kind of thing, this sort of dense scarring in the region of the AV node may actually cause heart block, just as sarcoid may cause heart block when it occurs in that region. It just occurs to me that for those of you in the audience who may not be familiar with MRI, I just want to point out that this is a technique where we give gadolinium, which is the dye, and we wait 10 minutes. And after 10 minutes, gadolinium has washed in and out of normal heart muscle. So normal is black, okay? Black is good. However, areas of fibrosis take longer to take up gadolinium, and they take longer for the gadolinium to wash out. So white is bad. So black is good, white is bad. And so when you have regional fibrosis like this, the LG technique works very well. You get this lovely contrast between black and white. But in reality, well, we'll come on to that in a second. I wanted to tell you one other thing first, which was that there's an interesting link in that the patients with fibrosis more often have elevated disease activity scores and more often evidence of elevated inflammatory markers like CRP and ESR. So there does seem to be some sort of link between how bad your disease is and the development of fibrosis. So maybe that's how we decide who we should image, because we're going to have to be selective. We can't image everybody. But I was going to go on to make the point that late gadolinium imaging is very good when you have focal fibrosis, a focal macroscopic scar, because then you can bring out this contrast difference, the black and the white, very easily. The problem is that lots of patients with lots of conditions, not just rheumatologic conditions, but including those, don't have macroscopic scars. They have a diffuse fibrosis on histology that can occur throughout the myocardium. And LGE imaging is really not sensitive enough to pick up that kind of diffuse fibrosis. And yet it's probably that diffuse fibrosis that's going to be important when we're thinking about progressive changes and maybe heart failure down the line. So fortunately, over the last 5 or 6 years, a new technique has emerged that's now widely used in MRI. And you may have heard of this term tissue mapping or T1 mapping, T2 mapping. And this is just a more sensitive pixel-wise ability to directly record the relaxation constant. It's a physics property, the relaxation constant in each pixel, both before and after contrast. And if that seems a bit technical, all it means is that we end up getting a value in milliseconds for each area of the heart. And we know what the normal range is in normal, healthy individuals at various magnetic field strengths. So here, for example, is a patient with systemic sclerosis who's had T1 pre-contrast, that's called T1 native, and T1 post-contrast. And they look like very pretty pictures, but actually on the workstation, you can probe the various areas of the myocardium and you can find out what the millisecond relaxation time is. And so here, even without contrast, we can see that there is a diffusely prolonged relaxation time. Post-contrast, we expect the relaxation time to go down, but it shouldn't go down as much as this. This indicates there's more fibrosis than we would expect in the heart. So we see this sort of thing in conditions like aortic stenosis and long-standing severe hypertension. And we suspect that this is part of the pathophysiology of developing heart failure with preserved ejection fraction down the line. So there's nothing specifically to treat when we see this sort of thing in a rheumatologic condition. But again, it may end up being a useful research tool for perhaps identifying a subcohort of patients who may be at higher risk of developing heart failure down the line. I just put this in to remind myself as well as you that myocarditis is sometimes the first presentation of a rheumatologic condition. This is an example from the literature of a 50-year-old man who presented with some typical features of pericarditis and myocarditis. Often the two things go together, myopericarditis. And he was treated in the standard way with colchicine and non-steroidals, and really didn't get better quickly. Still had a lot of malaise, poor appetite, weight loss. You know, some symptoms that actually are rather atypical for a simple viral myocarditis. Simple viral myocarditis, it comes and goes. It usually responds very fast to therapy. And in fact, this patient went on and had a lymphocytic rich pleural effusion, and I think subsequently had rheumatoid antibodies found as well. And then a few months down the line, developed typical arthralgias consistent with rheumatoid. The MRI here that was done, it's not terribly good quality, but I think you can see there's a little bit of myocarditis, a little patch of white here. Remember, white is bad, black is good, and some thickening of the pericardium with a rather complex effusion. But you know, as I said before, pericarditis is pericarditis. There is no way that the imager looking at this would be able to suggest that a rheumatologic condition was the cause. So there is a limit to the power of MRI, unfortunately. Okay, so although the literature that I looked at talks about pericarditis quite a lot in rheumatoid, in fact, as an MR imager, the patients that I seem to see the most are the SLE patients, and it seems that they often get quite severe rheumatoid. So excuse me, I just have to turn that off. It seems they get quite severe fibrosis sometimes. So this is a young woman. I think this is actually may have been one of Dr. Harvey's patients, but SLE seems to do really terrible things to the heart in my experience. So this young woman comes in, she's in her 30s. She has some mild heart failure symptoms and a mild reduction in ejection fraction. And she develops ventricular tachycardia while she's on the ward. And she goes for an MRI, and you can see why she develops ventricular tachycardia and why her function is down. So this is a short axis MRI late guided image. Again, black is good, but white is bad. And look at all this extensive subepicardial to transmural enhancement, almost all the way around. This is myocardial. This is not pericardial. This is a really nasty looking myocardial inflammation. And no wonder she was having episodes of VT. So she's given an ICD as prevention, as prophylaxis. Now that leaves us with a problem, because somebody with disease that's active like this, we want to, as imagers, to have some way of following it. And I'm sure that you will be using biochemical markers to follow it as well. But as imagers, it makes us uncomfortable if we can't follow something that looks like this. So in this situation, PET is often a good option. So positron emission tomography, PET, it's a technique where we use radio-labeled pharmaceuticals for different purposes. In this situation, we use a radio-labeled version of glucose, because in the inflammatory state, glucose is actively used to a greater extent by things like macrophages and neutrophils. And so sites of inflammation avidly retain glucose and therefore glucose tracers. And it can produce really exquisitely useful and interesting and helpful images. But the problems with it, I think, are threefold. And I'll show you some images in a minute. But the problems are, firstly, availability. Not everywhere has access to PET. There is a significant problem with reader expertise. There's quite a learning curve to recognizing abnormal from variants of normal, which might confuse you. And there is an issue with patient compliance. Sometimes this test requires the patient to go on to an Atkins type diet, a high fat diet, for a couple of days beforehand. And the reason for that is that we want normal, healthy, non-inflamed myocardium. We want that glucose signal suppressed. We don't want that myocardium taking up our labeled glucose. And so we try and suppress glucose utilization with an Atkins diet. And so what happens is only the most inflamed areas, which are really avidly taking up glucose, take up our radio tracer. So back to our lupus patient with VT. So at the time of her admission, shortly after, I think, her device was put in, she had a PET scan, which was called positive. It may be positive. It's hard to know. On the single image I have here, you can see that there's diffuse uptake in the myocardium, and that could certainly be a signature of diffuse inflammation. Unfortunately, that can also be a signal of poor dietary preparation, and so it's quite hard, without knowing how well she adhered to the diet, whether this is a real or not. But let's assume, for the purposes of the talk, that this is a genuine myocardial inflammation. And it may have been, because over the years, what we notice is that her LV ejection fraction slowly dropped and dropped. And by the time she was re-imaged in 2018, there was no longer any inflammatory component, but presumably this is now the end phase, the cold phase of the disease. And I think this raises some interesting questions about how often we should use PET to follow people with aggressive inflammation. And I want to show you a second case which emphasizes that point even more. So this is another nasty, horrible SLE myocarditis plus case, again in a young woman. And I can't remember how she presented, but for some reason she ended up going for a CT scan, a coronary CT scan. Presumably she had chest pain. And you can see, or hopefully you can see, this is the aortic root. And look at all this grayish thickening all around the root. This is all completely abnormal. It's abnormal thickening. It's either thickening of the aortic wall or it's inflammatory tissue around the aorta. It's hard to say, but it looks very abnormal. It's probably involving the valve as well, because she has at least moderate aortic regurgitation when you look at her MRI. And she went on and had an FDG PET scan. This is a coronal, this is a sagittal, and you can see that there is a fingerprint of glucose uptake throughout the ascending aorta on both of these images. So this is really quite unpleasant. And I think, when we saw this in particular, we're worried about what this might mean for the coronary arteries. So she went on to have her coronaries. Well, it was the same study. We looked at the coronaries, obviously, the same study. And interestingly, I think the study was read quite correctly as showing relatively mild osteal involvement of the coronaries. And this was at the initial presentation. Wasn't anything that was felt to need intervention at that time point. And then roll forward 3 years, and she returns with chest pain, and this time she has osteal stenoses in lots of places. I think it was LAD and circumflex. She had those stented. She came back a year later with a troponin rise and end-STEMI, had severe in-stent restenosis, and at that time had a new critical osteal right coronary artery stenosis as well. So she went on for aortic valve replacement and CABG, and unfortunately suffered LV failure and didn't end up surviving to discharge. So two rather unfortunate stories involving SLE, and I think they both raise quite interesting questions about how we should use PET and whether we should be more aggressive perhaps in using PET to directly guide management and really escalate management until the inflammatory signal has truly been suppressed. And maybe that's something we can talk about in the panel discussion. So I want to wrap up briefly by talking about myocardial perfusion. I think this is interesting because so many, as we've heard, so many of these patients do have chest pain, and it's not always large vessel angina that they're suffering from. So microvascular dysfunction seems to be really ubiquitous in rheumatologic conditions. It's been suggested that the pro-inflammatory state, together with aging and maybe other risk factors such as diabetes or obesity, hyperlipidemia, all contribute to create a scenario where microvascular dysfunction leads to symptoms and potentially leads to heart failure down the line. This is one of the best studies I've come across investigating microvascular dysfunction in this case in rheumatoid arthritis. And this was a PET study of 103 women who all underwent ammonia PET to generate quantitative flow reserve. And the interesting findings were that about a third of patients, in fact, had clearly reduced flow reserve, and that those patients who had lower flow reserve also had increased inflammatory markers. There was an inverse correlation between the two. And also, interestingly, if you were on a TNF inhibitor, because this was a moderately severe disease population in terms of disease activity, if you were on a TNF inhibitor, you actually had better flow reserve than if you had significant symptoms but were not on a TNF inhibitor. Another group, this time with SLE, and this time using CMR perfusion. This is a very straightforward technique. Any CMR center can do stress perfusion. This was adenosine stress in 20 female SLE patients and 10 controls. Everybody in this series had a coronary CT first to make sure they didn't have any large vessel disease. And what was very interesting is the prevalence and severity of defects in this cohort. So almost half the cohort of patients had visually appreciable defects, and that's this sort of low intensity signal that you see in the subendocardium. The myocardium should look gray like this, but the subendocardium is dark because of hypoperfusion. And not only were the defects reduced, or were there visual defects, but semi-quantitative measures of flow reserve were also abnormal, much more abnormal in the SLE group than in the control group. And it really doesn't seem to matter what rheumatologic condition you target or what technique you use to look at it. It's the same story. This is a rather interesting Japanese study where they took a bunch of SLE patients, a bunch with systemic sclerosis, and a number with rheumatoid arthritis. But here the imaging technique was echo, and they were actually looking at flow in the left anterior descending coronary artery under stress-rest conditions. That's a pretty challenging pretty challenging use of echo, so it's quite impressive, really. But they generated some very interesting data, both in terms of the frequency of abnormal MPR. So at least 2/3 of all the patients had abnormal myocardial flow reserve, and when you quantitated it in terms of a flow reserve index, all of the groups had significantly reduced flow reserve compared to controls, and this seemed to be particularly severe in the group who had systemic sclerosis. So I guess the question is, well, what do we do with this? Because we don't really know how to treat it. Should we be doing this in patients with chest pain? I think that's also a question for the panel discussion. I think there are some arguments for doing it in terms of helping patients to understand that their symptoms are real, that their symptoms are not in their head. It may give us renewed energy for trying to use certain medications to treat microvascular dysfunction, although it's not an easy condition to treat, but there are drugs that we can try. So I think that brings me to the last two slides, and really I started with the question, what lies beneath, and I think that begets an equally important question, and how hard should we look? Because there's a limit to what we can do. We can't use these expensive tests on every patient in the clinic, so who should get PET or MRI? And I've put up my suggestions here, and I'm sure other people have other ideas. I think the first three are relatively self-explanatory. I do think that persistent troponitis is important and maybe under-recognized. I don't know if it's under-recognized in the rheumatology world. I think it's under-recognized generally by cardiologists. Persistent troponitis in a cardiomyopathy population usually is bad. So in my personal experience, for example, with hypertrophic cardiomyopathy, the patients who have a chronic troponin leak almost invariably have significantly more scar than most other patients. So that's perhaps intuitively makes sense. So I think if they have persistent troponitis, they should have MR. And I think unexplained breathlessness as well, because really the last thing you want to do is be reassured by a normal echo and miss pericardial constriction. So if there's been any history of pericarditis and there is subsequent breathlessness, I really think that population deserve to have a CT or an MRI to try and exclude constriction. So with that, I suspect my time is up and I'll stop. I look forward to the discussion. Thank you very much.
Thanks, Andrew, for a masterful presentation of an area that I think is, we really need a lot more research. From my own perspective, as you know, I see a lot of these patients that have complex cardiac disease related to their rheumatological and autoimmune disorders. And I just have to pick up on one comment that you made, that we don't want to label people as having pericarditis if we don't have any actually hard objective evidence. Conversely, oh, you know, I've got quite a lot of experience here. Conversely, we don't want to be labeling people as having functional pain or MSK pain when in fact they have pericarditis. And I certainly have seen the patients who have had a normal echo and have seen multiple cardiologists and rheumatologists who have said, no, you don't have pericarditis because there's no effusion and no thickening on echo. And you've shown beautifully that we need to be using the advanced imaging to really be able to rule in or rule out pericarditis. And I can say that for all those patients actually that I've dealt with, when they've done the MRI, they've got pericarditic inflammation or fibrosis. So it's a really good lesson for all of us.
You seem to have a good radar, Paula. They were always abnormal. They were always horrendous.
It's listening to patients and and learning, as you know, from experience. Everybody that's participating would know that. There are several questions that have been entered, and I have all sorts of questions. We are running a bit behind time. I think we've done pretty well considering we've had a lot of presentations today. We are 10 minutes over time, and we do want everybody to have a chance to have a 10-minute break just to stretch their legs, etc. So, Andrew, we look forward to having you join us at the end when we do the putting it all together. Sure. And I'm sure there'll be plenty of questions from everybody, including myself.
Okay, I'll look forward to it. Thanks very much.
Thank you very much for your presentation.
That's a pleasure. Thank you.
So, hello again, and we are ready to get going with the second part of this symposium. This year, we decided to showcase some of the research that some of the trainees and the early researchers are doing with us within our program or in collaboration with us. So it is my great pleasure to introduce Keith Colaco, who is a PhD student that is working with Dr. Gladman and myself. Keith is working on studying ways to improve cardiovascular risk stratification in patients with psoriatic arthritis and psoriasis, and he's going to present a study that investigates serum metabolites and prediction of cardiovascular diseases in patients with psoriatic disease. Keith, take it away.
Great, thank you so much, Dr. Eder, for the introduction. So I'm very pleased again to be here today to share some of our team's latest work. And these are my disclosures. So today I'll be talking to you about psoriasis and psoriatic arthritis, which we also refer to as collectively as psoriatic disease. And these are both chronic immune-mediated diseases that primarily affect the skin and the joints. And as you've heard from Dr. Piguet this morning in his presentation, psoriasis as well as psoriatic arthritis are associated with multiple comorbidities. And there's very good evidence now that these patients have up to a 50% higher risk of developing cardiovascular disease. Now, very recently, metabolomics has emerged as a very popular method for quantifying large numbers of circulating metabolites in large population-based studies. And to me, it's a very exciting approach because it could help us to identify metabolic changes before cardiovascular events such as heart attack and stroke develop, potentially leading to earlier and more accurate identification of individuals that are at high cardiovascular risk. However, the relationship between metabolites and cardiovascular events hasn't been investigated in patients with psoriatic disease, as well as in the related inflammatory arthritis. And given what we know about the strong association between psoriatic disease, inflammation, and metabolic syndrome, metabolites could add predictive value over traditional risk factors. In this study, we aim to identify serum metabolites associated with a risk of developing cardiovascular events in patients with psoriatic disease, which could improve our understanding of the pathways that drive the increased cardiovascular risk in this population. And then we determined whether metabolites could improve cardiovascular risk prediction beyond traditional risk factors. So in order to do this, we used the University of Toronto psoriatic disease cohort and included patients with available serum samples and at least 1 year follow-up between the years 2002 and 2019. We also excluded patients with a history of cardiovascular events. And in this cohort, patients are assessed by a rheumatologist during routine visits, during which detailed information, including comorbidities, are captured in an electronic database. And for our approach, we used a targeted metabolomics platform, which uses an analytical technique called a nuclear magnetic resonance spectroscopy in order to quantify 68 metabolite measures. And then within 10 years of biomarker measurements, we identified clinical cardiovascular events that includes all of those listed here. So for example, angina and MI, heart failure, TIA and stroke, revascularization procedures such as angioplasty, as well as cardiovascular death. And then finally, we linked patient records to administrative databases in order to verify these outcomes. Now here I'm showing you the platform that we used that consisted of 68 metabolite measures. And here we focused mainly on a hypothesis generating approach in order to discover novel biomarkers and gain some insight into some of these disease mechanisms. So here, as I went in many categories, we use the platform to quantify routine lipids, total lipid concentrations of many lipoprotein subclasses, fatty acid composition, glycolysis precursors, ketone bodies, as well as amino acids. And then for the analysis, associations of each metabolite with incident cardiovascular events were analyzed separately using Cox proportional hazard models. And these models were adjusted for traditional cardiovascular risk factors that included age, sex, smoking, diabetes, hypertension, and body mass index. Now, since we started with a very high number of metabolites to test, in order to reduce the number of variables in our model, we used a penalization algorithm, and this model was adjusted for age and sex. And then finally, we assessed the predictive performance of the selected metabolites using the area under the curve. Now, overall, about 1,000 patients with psoriatic disease were assessed between 2002 and 2019. And during the follow-up period, 70 patients developed incident cardiovascular events. Now, just to briefly go over our sample here, about 65% comprised patients with psoriatic arthritis. The mean age of the group was 49 years old, with about 55% being males. And in the cohort, 16% are current smokers, about 21% on antihypertensive medications, and 10% on lipid-lowering therapy. Now, in this plot, we showcase all of the metabolites that were significantly associated with cardiovascular risk. And many of those associated with decreased risk, here along the top in blue, are what we know to be the good cholesterol. So these included high-density lipoprotein, or HDL, cholesterol, as well as medium and large HDL particles. And then as for amino acids, we found that alanine and tyrosine also had similar associations, but it's not well known by which the blood levels of these amino acids relate to cardiovascular risk. Tyrosine in particular has been associated with insulin resistance and the risk of diabetes in the general population, however. Now, along the bottom of the plot in red, metabolites associated with increased risk included atherogenic lipids and lipoproteins, such as apolipoprotein B and remnant cholesterol, which is composed primarily of the very atherogenic lipoproteins associated with the development of ischemic heart disease. And then lastly, with the metabolite at the bottom, glycoprotein acetyls, or glyc-A, has been a novel systemic inflammatory marker that is associated with concentrations of many cytokines, including TNF-alpha and IL-6. And in the general population, glyc-A has been shown to predict risk of all-cause mortality, as well as cardiovascular disease, even when you adjust for C-reactive protein. Now, after performing variable selection, among the 68 metabolite measures, 13 of them were selected in a model that was adjusted for age and sex. And as indicated by the negative coefficients here in blue, some of the metabolites were found to be protective of future cardiovascular events, such as DHA here, which is an omega-3 fatty acid, whereas other metabolites with the positive values on the right here under the red column were associated with future cardiovascular risk, such as glyc-A, which I had mentioned just previously. And next, we had tested the ability of 2 models to predict cardiovascular events in this cohort. The predictive performance of a base model, which included just age and sex, was compared to an expanded model that included age, sex, and the 13 selected metabolites. And we found that the expanded model demonstrated a significant improvement in predictive performance with an area under the curve of about 80 compared to the base model, which had an area under the curve of 72.6. And just to wrap up now, we identified a variety of metabolites associated with a higher risk of developing cardiovascular events in patients with psoriatic disease. And we found that most of these metabolites, which aren't routinely measured in clinical practice, offer a lot of interesting insights into the metabolic nature of not only psoriatic disease, but also atherosclerosis. We highlighted findings of apolipoprotein B, as well as glycoprotein acetyls, which validate findings in other studies of the general population. In our study in particular, we also describe potential underlying mechanisms of amino acids such as tyrosine and alanine, as well as omega-3 fatty acids, and their links to diabetes, obesity, and kidney disease, which are common among patients with psoriasis and psoriatic arthritis. And some of the biomarkers were selected in a combined model that included 13 metabolites in addition to age and sex, and we found this model demonstrated a good performance in predicting cardiovascular risk. Overall, our data point to metabolomics potentially identifying important risk factors for cardiovascular risk prediction, but also to pathways requiring additional research to understand some potential causal mechanisms in psoriatic disease. And it's my hope that this approach can be used with the related inflammatory arthritis, such as rheumatoid arthritis and ankylosing spondylitis as we head into the future. And with that, I'd like to thank my supervisors, Dr. Eder and Dr. Gladman, members of the research team highlighted here, our funding agencies, as well as special thanks to the patients who participated in this study.
Thank you, Keith. That was great. One quick question. We learn more about the links between metabolic abnormalities and the immune system. Can you tell us how inflammation would affect this metabolomic profile?
Yeah, of course. So it's, of course, very complex with these multiple cytokines that come into play. We know a lot of the pathways quite well in patients with psoriasis and psoriatic arthritis. But the complexity here lies in some of the circulating lipids, which are elevated in these patients and their interactions with some of these cytokines. We know that these interactions very early in age, starting as early as people in their 20s, can start the formations of some of these lesions in the vascular wall and really initiate atherosclerosis early on. And for clinicians, it's difficult because we can't really pick up on that until at a much later stage in people's lives.
Thank you. Thank you, Keith. So we'll move on now to the next presentation by Dr. Kostas Tselios. It is my pleasure to introduce Dr. Tselios, who is an assistant professor at the McMaster University. He's originally from Greece, and he completed his medical training there and as well as a PhD, and then moved to Toronto and worked with the Lupus group at the Toronto Western Hospital with Dr. Jurovitz and Dr. Gladman, and he investigated quite extensively cardiovascular diseases in patients with lupus. So Kostas is going to present today about hypertension in lupus patients.
So let me start by thanking Dr. Harvey and Dr. Eder for the kind invitation to present our work here for this Cardio-Rheumatology Day. I think it's really established now, an established platform for exchanging all this wonderful knowledge and this information about the cardiac health of rheumatic patients. So presented our work we published this last year concerning hypertension and systemic lupus erythematosus. I have no conflicts of interest for this presentation. So what is the problem with hypertension and lupus? You probably see hypertension everywhere. Like for all patients, for all people, elevated blood pressure is an important risk factor for atherosclerosis and cardiovascular events, right? What is happening in lupus? It has been reported in up to 74% of lupus patients, so almost 3/4. That's incredible, concerning that if you think that 7.7% is the prevalence of hypertension in healthy women 20 to 44 years of age. That's a major group for lupus patients. It's pathogenesis, multifactorial. We're talking about systemic inflammation with TNF alpha, IL-6, IL-17, plenty of other cytokines. In these patients, lupus nephritis, the renal involvement in lupus concerns metabolic constriction, concerns the activation of the renin-angiotensin aldosterone system and many other factors. And then, last but not least, steroids, non-steroidal anti-inflammatory drugs, other drugs that may impact blood pressure for this patient. So this is contributing to atherosclerotic vascular events in patients with lupus. We published a systematic review about 4 or 5 years ago. The increase in risk was anywhere from 5 to 350%, and hypertension was associated independently with all the stages of atherosclerosis, from impaired endothelial function to arterial stiffness, carotid intima media thickness, plaque formation, coronary atherosclerosis, every single stage from the beginning up to the clinical event. So a few years ago, we had published a review on hypertension and lupus with Dr. Jurovitz and Dr. Gladman. And we speculated based on experimental data when we should initiate therapy in the patients, what the target level should be, what the drug of choice should be, and of course the cardiovascular risk. We had trouble at that time. Why? Because the atherosclerotic risk estimators are not valid for lupus patients or for any other rheumatic patients. So now we have data to show what the target level should be. You're probably aware that in 2017, the American College of Cardiology and the American Heart Association published a new guideline where they defined 130 to 139 for systolic blood pressure and 80 to 89 for diastolic blood pressure as stage 1 hypertension. And since this is stage 1 hypertension, pharmacologic treatment drugs should be offered to all individuals with an estimated risk of 10% or greater, based on this ASCVD risk estimator. Right, and of course, in this paper, in these guidelines, there was no mention of patients with connective tissue disease, systemic autoimmune disease, even more lupus. Right, so the aim of the study was to assess the impact of exactly this new definition of hypertension, this 130/80 up to 139/89. what is the impact of this level of blood pressure in lupus patients and the risk for atherosclerosis. So we would treat patients with 2 years of follow-up plus one more visit, and that was the baseline. We got with 1,543 patients out from a total of 2,100 patients in the Toronto Lupus Clinic. At the time, we excluded patients with the previous atherosclerotic vascular event, so AVE before the baseline, and we calculated the time-adjusted blood pressure based on the actual reading we had in each clinic visit. Why we did that? And we didn't go with the orthodox way of, for the definition of hypertension, like 2 times, like a few months apart. Because we said that in lupus, blood pressure is fluctuating over time, and it fluctuates significantly because the patients had a short course of non-steroidal anti-inflammatory drugs, or because they had active disease that they're taking more prednisone than usual, or because the kidney involvement is active at the moment. So we opted to do this time-adjusted blood pressure and divide our patients to group 1 with a blood pressure, time-adjusted blood pressure over the first 2 years, less than 130/80. These were the normal tensive. The group 2 with a blood pressure of 130 to 139, 80 to 89. This is the stage 1 hypertension, or the new hypertensive, according to the new definition. And the old hypertensives, we all knew about them, blood pressure equal or greater to 140/90. Our endpoints were atherosclerotic vascular events, fatal and non-fatal. This is what is usually applied in the clinical trials of hypertension. We're talking about cardiovascular events, new onset angina, myocardial infarction, revascularization, procedures, and ischemic congestive heart failure. These are cerebrovascular events, TIA, and stroke, and peripheral atherosclerotic disease requiring angioplasty. So we had this. We checked the traditional risk factors and disease-related risk factors at baseline. Why we chose all these factors? Because we showed, based on a systematic review published, that these factors are independently associated with elevated risk for atherosclerotic events, not for any preclinical disease, but only for events. So if you see this table, there were multiple other traditional risk factors burdening the patients with stage 2 hypertension, this 140/90, and stage 1 hypertension, 130 to 139. For example, there were more males in the hypertensive group. They were older. They had more diabetes. They had more dyslipidemia. And of course, they had more damage from the disease itself. They had more active disease at the moment, based on the 3-DIA widely acceptable structure tool for the activity, for disease activity. They had more renal impairment and less glomerular filtration rate. They were taking less antimalarials, a well-known protective factor for atherosclerotic events, more steroids, and all of these things. So we followed all these people, again, 1,543 for more than 10.8 years. That was the average follow-up. And we detected 124 vascular events, including 20 cardiovascular deaths. And the cumulative incidence, we used a time to event analysis, actually. So we provided the results in patient years of follow-up. So the best group, the normotensive, had a cumulative incidence of 4.5 atherosclerotic vascular events per 1,000 patient years. These are the best that you can see here. With the yellow line, the middle group, the new hypertensives, 130 to 39, 130 to 139, 80 to 89. With significantly more events, 11.5 per 1,000 patient years. And of course, the classic hypertensive, more than 140/90, with 18.9 events per 1,000 patient years. And if you see this in different subgroups of events, these bars represent all the atherosclerotic vascular events. Red for the old hypertensives, yellow for the new hypertensives, and for the green, sorry, for the normotensives. These are the rates for the hard AVAs. When I say hard AVAs, I mean we took out angina and TIA, so we only had myocardial infarction, stroke, fatal and non-fatal. That was significantly different. I know there's some trouble with the answers here, and I apologize for that. I don't know why this happened, but in any case, there was a significant difference, statistically significant difference for all AVEs, for heart AVEs, for coronary artery disease events, not so for cerebrovascular events, I suspect because of the low numbers, and the significant difference when it came to cardiovascular deaths. So what was happening with the other risk factors? I told you a few minutes ago, because that these patients, this hypertensive group, both the hypertensive group, had the higher prevalence of other atherosclerotic risk factors, both traditional and disease-related. So we tried to test this out by using a multivariable analysis, time-dependent, for the predictors of AVAs, and we showed that stage 1 hypertension conferred an 80% increased risk for atherosclerotic vascular events compared to normotensive. So the same for stage 2 hypertension, 1.66 was the hazard ratio. And you will see the other factors that we knew from other studies: pre-diabetes, the overall disease activity, smoking, okay, steroids, and antiplatelets more likely as an indicator of prothrombotic states. So in summary, an adjusted mean blood pressure of 130, 139 to 80, over 80 to 89 over the first 2 years of observation was associated with 2.5-fold increase in the risk of atherosclerotic vascular events compared to the normotensive. And this level of blood pressure over the first 2 years conferred an 80% increased risk for atherosclerotic vascular events after adjustment for every other disease-related or traditional atherosclerotic risk factor. And the take-home message, what I would like you to remember, is that the target level, we consider now that the target level of blood pressure should be less than 130 over 80 for all of those patients. This is what we are doing now for the in the Toronto Lupus Clinic and in my new practice here at McMaster. And you can find more details in our published paper last year. I know we don't have any questions allowed, but I would like to thank, don't have an acknowledgement slide, because I would like you to remember this summary and conclusion. Right? I want to thank the Toronto Lupus Clinic, Dr. Gurwitz, Dr. Gladman, all the fellows, all the co-workers. It was an amazing experience. I was there for 6 months, and now I really miss them. And of course, I miss the group at the Women's College Hospital. We were working together for other projects. I hope that we'll cross paths in the future again. Thank you.
So, Lihi, if you allow me, I will take over. The next session is the clinical pearls, where we're looking at rheumatological and cardiological perspectives of a pretty complex case that we've been managing in the Cardio-Rheum program here at Women's College Hospital. We hope that people will find this interesting and a way of learning about a number of the different issues, cardiac issues that can occur in patients with the inflammatory rheumatic conditions. We have 3 presenters, and I'm just going to up front do the quick bio so that we can sort of have the flow through for this session. The first person presenting is actually going to be Lihi. And I really just want to say a quick few words about Lihi. We're lucky enough to have Lihi here as a clinician scientist at Women's College. And quite, as you know from participating in this symposium, she's also the co-director of the Cardio-Rheum network at the University of Toronto. Lihi is a stellar researcher, and her research really focuses on improving management of cardiovascular morbidities in rheumatic patients. And this is both through research and educational initiatives. She has a ton of publications in high impact journals. She has grants with CIHR, National Psoriasis Association, and she's won a number of early researcher awards. So we're just so privileged to have Lihi working with us here at Women's and at U of T. She'll be followed by Dr. Tosin Oceantoken, who is a cardiologist who did her training originally in Ireland before relocating to Canada. She's been working as a fellow at Women's College, and she's now got a foundation of expertise in cardio-rheumatology, complex hypertension, and she's also working with me in another area that's related to women and heart disease, which is dysautonomias. And so she's a wonderful addition to our team. And then we're going to finish off with Ophir Vinnick, who is a staff physician in the Department of Medicine at St. Michael's Hospital at University of Toronto. He's a clinician teacher who practices general rheumatology, but has a specific interest in inflammatory myopathies, as well as general internal medicine. He actually runs a specialised myositis clinic, and he's co-developed the joint neurology rheumatology myopathy program, so another multidisciplinary program. He's a referral source for adolescents with juvenile idiopathic myopathies that transition from Sick Kids Hospital, our big paediatric hospital at University of Toronto. So we're going to start with Lihi, transition to Tosin, and then finish with Ophir. And then we do have some time for questions at the end, but those questions that aren't answered, we can answer then in the Putting It All Together panel discussion. Thanks, Lihi.
Okay, thanks, Paula, for the very kind introduction. These are my disclosures. They are really not relevant to this talk, and Tosin does not have anything to disclose. So I'm going to present the rheumatologic part of this very interesting and complex course of disease of this very nice patient that keeps surprising us. So he's a 60-year-old man who works part-time as a geologist. He's a past smoker, and he's been following by myself in my psoriatic arthritis clinic since 2017. He presented with peripheral arthritis, dactylitis without axial involvement. And he also, like many other patients, had severe psoriasis and has failed several biologic medications for mostly because of active psoriasis, so including TNF inhibitors, Stelara, which is IL-12/23, and IL-17 inhibitors. And he has been doing well in terms of his skin and joint disease on ixekizumab, which is an IL-17 inhibitor. So like many of our patients, he was referred to the Cardio-Rheumatology for primary prevention in 2018. And as part of the workup that we do in the clinic, he had a cardiac CT to assess coronary calcium. He was found to have elevated coronary calcium score of 269. A score of more than 100 is considered high. His stress echo was normal though, and he had a normal troponin level. And based on these findings, even though he was asymptomatic, he was recommended to initiate treatment with atorvastatin and aspirin as a primary prevention. He was also found to have an incidental finding of a nodule in the right middle lung, and we recommended to repeat the CT at 12 months' time. So he repeated the CT, and unfortunately, at that time in 2019, he was diagnosed with adenocarcinoma of the lung. Although this was, because of this was more a screening test, this was found at a relatively early stage of disease. Due to the recent diagnosis of cancer, treatment with ixekizumab was stopped. And as a consequence, his psoriasis and psoriatic arthritis have flared. Around the same time, in February of 2020, he was admitted to hospital because of shortness of breath and he was diagnosed as having a non-ST elevation MI based on an elevation of troponin and ECG changes. However, his coronary angiogram found non-obstructive disease, and he was treated only medically. He was discharged in March, or he was discharged in February, and he came to see us in March. And I'm sure you remember, March was the beginning of the pandemic here, at least in Toronto. Everything was under lockdown, and we were working in very reduced capacity. I think that was a sort of luck that he's the kind of patient that doesn't complain, and he called and he was saying that he was really doing unwell, and I told him, please come over, I want to see you in person. And I'm glad I did that, because when I saw him and examined him, he was clearly very weak. He had a progressive proximal muscle weakness in the upper and lower extremities. We did some blood tests, and he was found to have very high CK levels. His serology was positive for ANA with positive RNP and SSA. We didn't do the myositis-specific antibodies at that time. Again, because of the context of the pandemic, it was very hard at that time to achieve these special tests. Because he was rapidly progressing, and fortunately we had Ophir Vinik agreeing to assist in the care of this patient. We admitted him at St. Mike's Hospital, and he underwent a workup that included MRI of the muscles that showed very typical edema and fat atrophy of several of the proximal muscles in the legs that were typical of inflammatory myositis. He was also found to have some changes that are in keeping with interstitial lung disease, again, that is typical in the context of inflammatory myositis, and a diagnosis of inflammatory myositis was made at that time. Again, we didn't do all of the additional tests that might be done under more regular circumstances, like a muscle biopsy, because we thought the case was very typical, and because of the context of the pandemic and so on. So this was sufficient for a diagnosis. He was treated with IV solomedrol and IVIG for 3 days, and then was discharged on high dose of prednisone and mycophenolate mofetil as a steroid-sparing agent. And he showed very rapid improvement in his muscle strength and normalization of his CK levels. And we were slowly tapering down the dose of prednisone up to a dose of 10 milligram in April of this year. In terms of his lung cancer, this was deemed high risk for surgical resection, even though it was a very early stage and there were no metastases identified. Because of his cardiac condition, this was deemed inoperable at that time. So he was treated with radiotherapy that showed a significant improvement in his lung findings. And his interstitial lung disease was considered to be relatively mild and stable, and didn't require any specific therapy beyond the treatment that we were providing him for his inflammatory myositis. So I'm going to turn it over now to Tosin, who is going to review the course of his cardiac disease.
Just to continue, Mr. RK was assessed urgently by us initially in April of 2020 at the request of Dr. Eder. So as described previously, he had presented to his local hospital in the February of that year with dyspnea, ECG changes, and a positive troponin, and was treated as a non-ST elevation MI. Coronary angiography at that time showed normal LAD, mild disease in the right circumflex, and a 50% proximal and 80% distal circumflex stenosis. He was treated medically. At the incident hospital admission with the inflammatory myopathy in March, of last year, he was found to have significant troponin elevation, much higher than it had been in February with the non-STEMI. The high sensitivity troponin was 2,666, again, higher than we would expect with another non-STEMI. He had a cardiac MRI while he was an inpatient, and that showed findings consistent with a prior MI, likely involving the circumflex territory, as well as a small focus of non-ischemic scar, which was described as probable myocarditis. This image here is just a representative image from the literature showing mid-wall late gadolinium enhancement in the septum, and as well as lateral late gadolinium enhancement. So when we saw Mr. RK, he was on dual antiplatelet therapy with aspirin and clopidogrel. He was on a beta blocker. He was on high-dose steroids and immunosuppression. He was improving, but clinically still described some shortness of breath on stairs and very occasional palpitations. On that day, he was in sinus rhythm and had a normal LV function on echo and clinically was euvolemic. The troponin T at our institution was elevated as well as the BNP. We followed up with him again in June, and actually at that point he was very well. He had no chest pain, no shortness of breath. He had returned to work, which involved working on a construction site, working very long hours and being on his feet. The troponin had started to normalize, and the BNP remained elevated. At that stage, we added an ACE inhibitor in view of the persistent BNP elevation and mildly increased LV volumes on echo. Mr. RK did describe an episode about 10 days prior where he had irregular palpitations that lasted for 12 hours. And in view of this, we organized a Holter monitor that he had done locally. This was important in the setting of his history so that we would not miss a ventricular arrhythmia, supraventricular arrhythmia, or any pauses. The Holter monitor showed atrial fibrillation, which with a controlled heart rate of about 80 beats per minute. And at that point, we increased his beta blocker dose and stopped the clopidogrel and started him on edoxaban. So this anticoagulation was chosen after discussion with the team and review of the literature because it has a slightly reduced risk of bleeding in patients who have cancer. We continued to follow him closely over the summer, and he remained well and stable, and his troponin I was completely normalized at that point on the combination of immunosuppression as well as maximally tolerated cardiac medication. As Dr. Eder described, he did undergo radiation therapy for lung cancer at that point, and had described some fatigue after this. In the fall, he described more frequent palpitations, and a repeated Holter showed atrial fibrillation with faster heart rates. So the heart rates were now between 110 to 120 beats per minute, associated with symptoms. The LV function was about 50% on echo, and we referred him to our electrophysiology colleagues for assessment, and he underwent a successful cardioversion to sinus rhythm. In March of this year, he continued to describe shortness of breath and fatigue on exertion, although the palpitations were much better after the cardioversion. The troponin T at our institution was elevated and the BNP had never normalized. In view of the ongoing shortness of breath and fatigue on exertion, we decided to do a follow-up echo as well as liaise with our respirology colleagues. So the echo actually showed mild improvement in his ejection fraction post-cardioversion from about 50 to 55 to 60%. And the pulmonary function test and 6-minute walk test were unchanged compared with January of this year. He continued on his medication and remained stable until he contacted our office in April and described 2 syncopal episodes over a period of 3 days. On hearing this story, we urged him to attend his emergency department, but he actually needed some convincing to do so because he felt that he was otherwise stable. Thankfully, he was admitted to hospital because in the first 24 hours, he had a syncopal episode in the washroom on telemetry, and this showed a period of asystole for 10 seconds. He had a temporary wire inserted and was transferred for a dual chamber pacemaker. So in summary, this is a complex, a very rare, and actually evolving clinical case. We feel it highlights the multidisciplinary care of our cardio-rheumatology program. We also involved the care of our respirology colleagues and had to liaise with the lung cancer team to change his treatment management options for lung cancer. With respect to the cardiac findings, there are likely contributing underlying issues: the coronary artery disease, myocarditis, atrial fibrillation, and progressive conduction disease. I'm going to hand over to Dr. Vincent here. Thank you.
Hi there. Thank you. Hope you can all hear me well. Thank you so much for inviting me to talk today. I'm very mindful of the time, so I will probably modify as I go along some of the slide, and we'll probably skip some of the slide just for the sake of time and hopefully leave some time for discussion. And I'm going to talk to you today using that case as the background to talk to you today about inflammatory myopathies and their cardiac manifestation, which is truly a total eclipse of the heart. Sorry, I couldn't resist that, and I would make a few other song references during the talk. I don't have any disclosures. And as I said, I'm going to go over as a bit of a background on the inflammatory myopathies, but focus primarily on their cardiac manifestations and give a bit of kind of approach to investigation and management of inflammatory myopathies with focus on cardiac manifestations. So the field of inflammatory myopathies is a very exciting field. I'm biased, but I think it's the most exciting area in rheumatology these days because it has really undergone a tremendous paradigm shift over the last 10 to 15 years. Gone are the days of dermatomyositis, polymyositis, and with the understanding that inflammatory myopathies are truly a wide spectrum of clinical, serological, and pathological entities. And this is one early attempt from 2014 to identify this clinical syndrome, try to group them together, recognizing that even within each of these type of syndrome, you have a very broad heterogeneity of manifestations. Not all patients have rashes. Not all patients have muscle involvement. And the involvement of each organ can vary in terms of severity. And a key point to make, which I think is also very relevant to this case, is the fact that there are a lot of overlaps, and overlaps are probably more the rule rather than the exception in terms of manifestation and serology as this slide is trying to capture here. There has been many attempts to try to come up with a classification or diagnostic criteria, and this is the most recent one from 2017. But even this most recent one, which is quite comprehensive, has its own pitfalls and limitations. And one big one is the fact that it does not incorporate the myositis antibodies that I'm going to talk about in a moment, and their role in characterizing and diagnosing the condition. The myositis antibody panel that I'm referring to is available in Ontario, and it includes these 16 antibodies. Some of them are specific, some of them are associated with inflammatory myopathies. But it's important to recognize that although some of them are quite specific, they're certainly not diagnostic in themselves, and they're not very sensitive. They're found in about 60 to 70% of patients with inflammatory myopathy, so not everyone. And another serologically relevant point to make is that many patients with inflammatory myopathies are ANA negative, so that's certainly not a good tool for screening. Unlike lupus. The prevalence of the different antibodies really varies based on the study that you read, and this is just one example. The reason I like that slide is because it also highlights the overlap, the fact that sometimes you can test positive for more than one antibody. So there are clinical overlaps and serological overlaps, and that contributes to the complexity of this spectrum of conditions. I'm going to skip those slides, which were just meant to give a bit of examples of the different antibodies, because I do want to focus more on the heart. But it is important to make the point that the trouble with myositis is, one, that it's rare. As I mentioned, we don't really have great criteria for classification or diagnosis. The studies are very limited, very small scale, many of them prospective or small cohorts. Many of the quoted studies refer to studies from the 70s and 80s, and they have not been replicated. And most of all, I think it's the incredible heterogeneity that makes it quite challenging to come up with general statements about these conditions. I'm going to skip this very quickly. This really speaks more generally about identifying patients with inflammatory myopathies. So I'm going to do this part fairly quickly so I get to the cardiac part of the talk. But the investigation and diagnosis of these patients start first and foremost with history and physical, and I can't overemphasize the importance of that. Most of these patients do have some degree of muscle involvement, so a physical exam looking for weakness is really key in the initial diagnostic process. Blood tests that look for biochemical muscle markers is another key part of the process, but recognizing that 10 to 15% of patients with inflammatory myopathies with muscle involvement can have a normal CK. Normal CK certainly does not exclude inflammatory myopathy. If the patient is weak, that matters more than if their CK is normal. And other biochemical parameters that can be helpful are LDH and the aminotransferases that can be of muscle origin. EMG is another useful tool in the diagnosis, but not specific or diagnostic in itself. Helps you identify a myopathic process, but many times cannot really tell you what that process is. So it's a good screening type of test, but you many times need more investigations, particularly a muscle biopsy. And muscle MRI has become a very common tool that we use to identify muscle edema. We're using a T2 weighted images, and it helps to identify areas of edema. It helps to guide the muscle biopsy, and can also help distinguish between active disease and changes of chronic damage or atrophy to the muscle. And this slide is just an example. On your right side, a positive test where the muscles stand out because of edema. This is a fat-suppressed sequence. There is no need for a gadolinium here compared to a normal on the left side. I would make the important point that muscle edema in itself, again, is not diagnostic. It can be suggestive of inflammatory myopathy, but at the end of the day, for a more definitive diagnosis, muscle biopsy is really key in the diagnostic process. So with that brief background in terms generally of inflammatory myopathies, I do want to focus more on the cardiac manifestations. And I think this case that was presented before really highlights many of those potential complications. A real challenge in talking about this topic is that the prevalence is really unclear. This is one of those manifestations where when you look at the prevalence, it's 5 to 75%, which really speaks to the very limited data that we have. Many of the studies that looked into it are not necessarily uniform in their approach. Many of the patients included didn't have muscle biopsies to confirm the diagnosis. Many studies that talk about prevalence don't have a control group to see how the rates of cardiac issues compared to the general matched population. But what we do know is that it certainly has an important mortality effect in patients with inflammatory myopathies, with rates that are quoted as, I would say, on average 10 to 20%. We also know, similar to RA and lupus, is that traditional cardiovascular risk factors seem to be more prevalent in patients with myositis, and there is a significant increase death rate from myocardial infarction, especially in women when it comes to inflammatory myopathies. The pathophysiology, the direct information that we have is very limited. It comes, of course, from autopsy studies, and those are very few. But from what we know, it seems to be a similar type of process to what happens in skeletal muscle, where there is inflammatory infiltrate leading to some fibrosis and necrosis. And I will get back to the pathophysiology again a little bit later as we talk about these specific manifestations and how this pathophysiology can relate to that. Clinically, when we think about cardiac manifestations, there are a few key points to realize and appreciate before we talk about the specific ones. One is the fact that cardiac myositis, or involvement of the heart in patients with inflammatory myopathy, is invariably associated with active skeletal muscle disease. To have no skeletal muscle involvement and just a cardiac involvement would be extremely rare type of way of manifesting these complications. And there isn't necessarily a clear correlation with disease severity. You don't have to necessarily have severe inflammatory myopathy to have cardiac complications or cardiac manifestations. The way I conceptualize cardiac manifestations in inflammatory myopathy is to think about clinical and subclinical. And the reason is that overt clinical involvement, meaning overt symptoms of cardiac involvement in patients with inflammatory myopathy, is actually quite uncommon. many patients have subclinical involvement. If you don't look for it, you won't know that it's there. And I use that type of paradigm to think about the different manifestations which are included in this table here. So on the right side, clinical, meaning the patient has actual overt symptoms compared to subclinical. Early means early on in the disease or when the disease overall is active and more acute, compared to protracted, which means later on in the disease is not necessarily active, and some of the cardiac complications. And if I were to summarize, I would say that congestive heart failure with impaired LV function and cardiac arrhythmias are probably the most common cardiac complications that we see in patients with inflammatory myopathies. In the early, more acute, clinically manifesting presentation, what you might expect is congestive heart failure and myocarditis type of clinical picture, as well as arrhythmias. Acute pericarditis is quite uncommon presentation or cardiac manifestations. Subclinical, the patient does not have symptoms but have cardiac involvement. That usually would manifest with various ECG changes that I will outline in a moment. Protracted, meaning later on in the disease, not necessarily when there's active symptoms of general kind of inflammatory myopathy disease process, would be conduction abnormalities when it comes to clinically manifesting symptoms, pulmonary hypertension, as well as MI, and subclinical coronary artery disease. Now, trying to tie these manifestations to the pathophysiology, I have this slide here that tries to put it together and showing how the local inflammation in the heart, if the cardiac muscle is directly involved, the effects of systemic inflammation, plus traditional cardiovascular risk factors that seem to be more common in patients with inflammatory myopathies, combined together to affect the vasculature, the conduction system, and that's either through inflammation or even more so by necrosis and band necrosis in the cardiac muscle that will then lead subsequently to conduction abnormalities. And those factors, either together or apart, they can then impair the cardiac function, resulting in heart failure. I wanted to go back for a moment to the subclinical cardiac involvement that I mentioned, because that's very important. These are manifestations or involvement that you wouldn't know about if you weren't looking for it. Patients usually do not have, or many times might not have symptoms, but these are typically ECG changes, and these can be atrial or ventricular arrhythmias. Bundle branch blocks are probably the most common of these ECG abnormalities, including AV blocks. But as you can see, it really spans a broad spectrum of conduction abnormalities. So how do you evaluate the patient with inflammatory myopathy with respect to the heart? And you start first and foremost, I always emphasize that, by good history and physical detailed system review, and specifically looking for cardiac manifestations, signs and symptoms of heart failure, syncope, pulmonary hypertension, because that really helps you to know how far to kind of investigate and what's your pretest probability for these tests. One of the first and probably one of the key things that you would want to do upfront is include or test the troponin. And I want to do a bit of a segue to talk about the troponin, because that's a question that comes up quite often. So I mean, generally troponin, as I think you all know, is part of both cardiac and skeletal muscle protein family, and it has 3 isomers, the troponin I, C, and T, as you see in this diagram. The one that we these days think most when it comes to the heart is the cardiac troponin I. Now, troponin I stands for inhibitory because it has an inhibitory effect in the muscle, preventing myosin from binding to actin in a relaxed muscle. That's why it's troponin I. And the high supersensitive cardiac troponin is usually either I or T isoform. If it's not cardiac specific, then it can come from skeletal muscle. So you need to know what your lab is actually testing to try to figure out whether there might be confounding effect to your results. And when we look specifically, and this is a great reference if you really want to read more about this topic, about the effect or the impact of skeletal myopathies on the troponin testing. Because one of the questions that comes up is it real? Is the troponin real? Is it maybe coming from skeletal muscles? So I would say about that, what I would say about that is that the high sensitivity cardiac troponin could be affected in the context of skeletal myopathies, and that's particularly true to the T isomer, but the I isomer would be quite unusual. Now, how does that happen? The mechanism and the assay-related issues are not fully understood from what I know, but there is that possibility. Nevertheless, what I would say is that if the highly sensitive cardiac troponin, especially cardiac troponin I, is elevated, you would want to exclude cardiac etiology. I wouldn't, assign it to an assay problem or confounded by skeletal myositis. Other labs that you can do, not always necessarily easily available when you might need to ask your lab specifically. You can do a CK-MB to total CK ratio, and that can help to point to a cardiac origin. And BNP when we think about heart failure. So that's from the lab point of view. Electrophysiologically, ECG, I would say doing an ECG at time of diagnosis is key, especially to identify those subclinical arrhythmias that patients might not have symptoms. You can follow that with a Holter monitor. That's when your history and physical go into play and the result of the ECG. The other test that will be important, and that's a test that I would say I do pretty much in all myositis patients, especially with around diagnosis, is a 2D echo. And this is a table from a systematic review that was published in 2012 that included 1,530 patients, and looking at the frequency of various echocardiogram abnormalities in patients with inflammatory myopathies. You can see that the frequency really ranges widely, but left ventricular dysfunction seems to be an important one to look for. But as I mentioned in the beginning, truly a total eclipse of the heart, every part of the heart could be potentially affected. The other test is, as you saw in the case that was presented, is a cardiac MRI with gadolinium. Now that can be a talk in itself because there is a lot that can be said about cardiac MRIs, but I will try to really kind of narrow it down to say that the cardiac MRI with gadolinium really has two main functions in the context of inflammatory myopathy. The T1 weighted images that can identify fibrosis, and that can be a sequelae of inflammation. that can then lead to complications like conduction abnormalities, and T2-weighted images that can identify edema and inflammation. The challenge, which we have very often in these patients, in a rare entity, is that the sensitivity and specificity in the context of myositis of cardiac MRI is really not established. What I have for you here is from a paper in Circulation in 2017 that looked at the sensitivity and specificity of different sequences of cardiac MRI to identifying general acute myocarditis, so this is not specifically to myositis. And as you can see, the different sequences have about 75 to 85% sensitivity of identifying myocarditis generally, but again, this is not in myositis patients. We don't really know what it is for myositis patients. At the end of the day, I mean, the gold standard, of course, would be an endomyocardial biopsy with respect to cardiac involvement in myositis, but this is very, very rarely, if ever, actually done. So treatment-wise, this is just a general principles to treatment of patients with inflammatory myopathies, emphasizing the importance of non-pharmacological interventions in these patients, physio, rehab, really key in patients, and the pharmacological piece, which includes immunosuppressive medications, of course, and this slide summarizes some of the key medications that we use. I'm not going to go into that as part of this talk, but rather focus more on cardiac specific. Now, that being said, there isn't really a cardiac specific treatment when it comes to immune suppression. And the challenge with the treatment is that corticosteroids, which are really the cornerstone of treating myositis, inflammatory myopathies, is that it's truly, when it comes to the heart, it's truly the case of the good, the bad, and the ugly. The good, they help, and patients improve, and the heart, if the heart is involved, it improves together with the rest of the disease. The bad part is that steroids, as we know, can make things worse when it comes to the heart and can exacerbate or lead to fluid overload, fluid retention, heart failure. And the ugly is the fact that steroids do not always help with cardiac manifestations of myositis. And this is particularly true when it comes to the conduction abnormalities. And this brings us back to the pathophysiology, where inflammation can lead to fibrosis, band necrosis in areas of the cardiac of the heart, which would then lead to conduction abnormalities. No amount of steroids that you're going to throw at it is going to help because it's fibrosis. That might happen as a sequelae to previous inflammation. So this is an important point to remember about steroids and cardiac manifestations of myositis. And that was actually recognized going back to the early 80s, as you see here on the slide. How do you manage the heart failure and conduction disorders? Well, that's definitely the time where you want to call your friendly neighborhood cardiologist, which truly highlights the fact that the care of myositis patient should be and is truly multidisciplinary. These are systemic diseases with multi-system organ involvement many times, and it requires the expertise of the cardiologist to help with the non-immunosuppressive piece of the management, from rate control, rhythm control, and so on. So to try to put it all together, this was suggested as part of the systematic review that I mentioned before, published in 2012. There are no real guidelines when it comes to this topic, and the evidence, as I mentioned, is very limited. But they tried to put in this flow diagram, which I think is fairly good, starting with once you have the diagnosis, evaluation of traditional cardiovascular risk factors, blood pressure, blood glucose, cholesterol, and so on. Detailed history and physical, looking for cardiac symptoms, signs and symptoms, and then doing ECG and echo. I don't know if every year I don't think there is really evidence behind it. I would certainly say with diagnosis and if there is any concern, and I definitely repeat echo even a few years later, thinking about pulmonary hypertension, similar to what we do with other connective tissue diseases. If you do detect an abnormality, especially conduction abnormalities, doing a Holter, the biochemical testing with troponin, as I mentioned before, and then cardiac MRI is another modality that can be useful, especially when thinking about myocarditis or fibrosis. So to summarize the key points, as I mentioned, first and foremost is the general take-home message about inflammatory myopathies and how broad and heterogeneous this group of condition is, and that cardiac involvement is likely more common than we thought. And part of the issue is that presentation can be subclinical. If you don't look for it, you might not see it. So you do want to include some basic cardiac testing at diagnosis and follow-up as clinically indicated, as I mentioned, and finally highlighting the importance of multidisciplinary care for these patients. So I'm going to pause here, and hopefully we have some time for questions.
Thanks, Sophia. That was just a fantastic presentation and answers a lot of the questions and raises the same questions that we've been asking in our case and that I encounter also with a lot of the autoimmune and inflammatory rheumatic conditions. Great use of pop culture, by the way. Bad and the Ugly and Total Eclipse of the Heart, so movies, songs. You're doing a great job there, and it's a way of us always thinking about the extensive range of cardiac complications of many of these disorders. And the reason that we need rheum card or cardio-rheum, depending on which perspective you're coming from, whether it's the rheumatological or the cardiac perspective, but working together is really important, and that certainly has helped us with this case that we presented. It also, you've really highlighted a lot of the issues that I have encountered as a cardiologist that works in this field over 20 years now. When you look at the total eclipse of the heart, so we talk about CAD, but all the other issues that are associated with these conditions, and how we have actually such a dearth of evidence and research and guidelines to follow when we're looking at, whether it's myocarditis, pericarditis, valvular disease, etc. And the complexity of the sort of this dislocation between the severity and the progression of the underlying rheumatic disorder and what we actually see from a cardiac perspective. And that's, we see that perfectly in this case with the conduction abnormalities that were progressive even when we brought the sort of underlying inflammation pretty much under control. And we see this also, as you would know, with pericarditis or pericardial effusions, valvular disease. So lots of research, I think, that needs to be done, and you've highlighted that beautifully. So we are a little bit over time. Lihi, I'm going to confer with Lihi here. We can either take some questions now or we can jump into the panel discussion and address the questions in the panel discussion.
Well, I guess maybe Ophir can take one question from the audience. There is one question from Maureen Dwight that is asking, physiotherapists may see clients who have symptoms suggesting of undiagnosed myositis. Which muscles should be tested and what level of strength loss is significant enough to consider referral back to their physician?
Okay, thank you. Yeah, excellent question. Identifying these patients can be a challenge. It's important to keep in mind with inflammatory myopathies in the context of connective tissue disease, we're looking at proximal muscle and we're looking at very symmetric type of presentation. So if you see patient with symmetric proximal muscle weakness, and what I mean by proximal is these are the deltoids, biceps, triceps, neck flexors in the upper extremity, and in the lower extremities, hip flexors, which are probably the most commonly affected muscle, hip extensors, as well as knee flexors and extensors. When it comes to distal muscles, you want to think more broadly, and that brings into light other muscle conditions. If you're getting into wrist, ankle weakness, finger weakness, you would not expect that with these inflammatory myopathies. I would say any degree of proximal, fairly symmetric muscle weakness should prompt you at least basic investigations, as I mentioned, CK, maybe an EMG, basic labs to start with.
It's a great point. It's always difficult to know when to be referring and not to be sort of over-diagnosing what might be a pretty rare condition. So I think what we will do, the final session for today is the putting it all together, the panel discussion. And we're going to bring all of the speakers together and we'll be open to questions. So we really can have a fulsome discussion, multidisciplinary discussion. And that's actually going to be moderated by our colleague, Dr. Ruth Heisey. Ruth is the Chief of Family and Community Medicine here at Women's College Hospital. And she's the medical director of our Peter Gilgan Centre for Women's Cancers. She's also a clinician investigator and an associate professor at the University of Toronto. And Ruth has kindly agreed to moderate the session for us. And it will be our closing session. And we'd really like everybody to stay with us because I think there's lots of interesting perspectives that we can discuss.